Yes.
Okay, good morning. Okay, so let's start. Good morning and assalamu alaikum. Welcome you all to the Shaukat Khanum Symposium 20th. This is the pain medicine session today, and I'm Dr. Rumana Durrani. I'm consultant anesthetist and pain medicine consultant in Shaukat Khanum Memorial Cancer Hospital, Lahore. So we'll take the questions at the end of the session, and we'll have 5 talks first. Our first speaker is Dr. Usman Bashir. Dr. Usman Bashir is currently working as a consultant anesthetist and pain management in National Hospital and Medical Center, Lahore. He worked in United Kingdom for 14 years, where he did his fellowship in anesthesia, earned his CCT, and has done advanced pain training fellowship in pain medicine from Royal College of Anesthetists. He worked as a consultant in anesthesia and pain medicine in a tertiary care center in Glasgow before moving to Pakistan in 2018. He was a clinical lead for standards of chronic pain at regional level in Glasgow. He has been actively contributing to pain education and development of the specialty since the move through the various national and international platforms, Essential Pain Management Education Initiative being one of these examples. He has been gifted with the natural talent to play the musical instrument as a hobby. He particularly plays very well violin and rhubarb. He is a strong believer in multidisciplinary teamwork in pain management, and that is what he is going to talk to us today. So here we go with Usman Bashir. Over to you, Usman.
Assalamu alaikum. Thank you, 20th Shaukat Khanum Cancer Symposium organizing team for inviting me as a faculty. And I'm honored to be presenting here and opening the pain session. The topic given to me is rather a soft one and it's quite broad compared to the topics further upcoming in the program. However, I strongly believe that the implications and the impact of this particular area is huge if applied in our clinical practice. So that's why we chose this topic to be presented. And the way we are going to go about it is by talking about some working definitions, the rationale behind the team approach in pain management, what evidence supports it, what constitutes a team, what is a clinic versus a multidisciplinary pain center, and how we in low middle income countries can work as a team. What challenges do we face and how to overcome them? So first, some working definitions. Of course, any talk about pain is incomplete without definition of pain, which is the latest 2020 IES revised definition, where it does highlight the emotional component as well as sensory. So emotional part is quite important when it comes to the development of team. We'll look ahead. Two key concepts are multidisciplinary and interdisciplinary treatment. Multidisciplinary is when the treatment is often by healthcare professionals of various backgrounds. However, they are working on individual basis on their own treatment goals. They may not be coordinating with each other. Whereas interdisciplinary means a multimodal treatment provided by a multidisciplinary healthcare team which coordinates the assessments with the combined treatment goals by regular meetings. So here's another table highlighting the same aspect. It's the interdisciplinary approach, which is mainly propagated by all the working bodies and official organizations in developing country. For the purpose of this talk, I'll retain the term multidisciplinary because this is the term which we are more familiar with so that we don't create any confusion. So we now go into the rationale for teamwork in chronic pain management. And the very foundation of this is the biopsychosocial model, which implies that if the pain, whether it is acute or chronic, it is a multifactorial condition which has biological, psychological, and social contributors. What it actually means that all these contributing factors contribute to the experience of pain, and they integrate with each other, and eventually they affect the health-related quality of life. So, for example, if the pain is chronic, it can cause significant disability, and that disability can have biopsychosocial components and consequences, as you can see in the image here. And all of it affects the health-related quality of life. So when you talk about such a complex, multidimensional aspect of chronic pain, then a single treatment approach by a single specialist may not be sufficient. And that's where the biopsychosocial approach focuses on the multidisciplinary team approach. To achieve the targets of long-term pain management involving various specialist treatments from various group of healthcare providers. And this forms the very basis of the need for the team in pain management. When you form a team has certain advantages. There are some genetic advantages which any team will bring in terms of productivity, safety, stress reduction, shared work environment, mutual trust, and conflict resolution. But there are some specific advantages in terms of the pain management specialty, that overall the cost is less. And apart from reducing the pain, when you apply MDT treatments, you improve the quality of life, you improve physical mobility, you improve psychological well-being, and prevent the secondary dysfunction. Another advantage is you prevent over-investigating and over-utilization of interventions. Prescription drugs, analgesics, you can prevent the overuse of these as well. And as a team, then you focus on providing evidence-based treatments which are safer for the patient. So talking about the evidence, we need to look at what actually supports in terms of evidence. When we look at the evidence, it dates back as much back to 1970s, and the quality of the evidence ranges from multidisciplinary randomized controlled trials to meta-analysis, all the way to systematic reviews. There have been a lot of randomized controlled trials comparing the multidisciplinary treatments with the single modalities. Now, we don't have time to go into the details of these. We'll touch base on a few bigger ones. Floor did a systematic review back in 1992, where they found that multidisciplinary treatments are superior to single treatments, not only for pain, but for mood, behavioral aspects, and return to work. This graph here illustrates that the pain management programs, compared to the standard treatment modalities, work almost comparably when it comes to percentage reduction in pain. However, when you look at the cost of these multidisciplinary programs, it is much less in terms of bringing the patient back to the working life. So another big advantage of a multidisciplinary team approach. A recent systematic review by Skelly et al. Looked at about 233 randomized controlled trials, and they also proved that all the non-invasive, non-pharmacological treatments for chronic pain, the advantage in terms of improvement of function goes much beyond the course of therapy. There are lots of studies from Europe, North America, and Australia. However, there's quite a scarcity of evidence when it comes to South Asian subcontinent. So we found one study from Cordosa et al., which looked at 70 chronic pain patients, which were monitored for about 1 year, and they showed significant improvement by implication of MDT tools. However, this was only a case series, and there was no comparison with other treatment group. Nevertheless, it can still be applied as a effectiveness trial where it confirms the finding of the previous RCTs. But what this study does imply in terms of the clinical practice in our part of the region is that despite the non-Western cultural background, the MDT treatment modalities were proven to be effective. Therefore, patients do have a right to access these treatment options. And there's a dire need for urgent research in this area. So when we looked at these areas that the scarcity of research, that prompted us to do some more background analysis of the practices and joined with the Aga Khan team. We wrote up an article, recent article related to teamwork and its barriers in low middle income countries, that was published back in April this year, and we worked with Aga Khan team for that. As far as the renowned larger bodies and organizations are concerned, there's some fresh, hot, off the press publications. A big one out of these is the IASP toolkit, which they have produced for developing countries. They have empowered the developing countries by producing this manual to help them develop a multidisciplinary team approach and the centers. We'll be talking a fair bit about this manual in the talk. More recently, Faculty of Pain Medicine of Royal College of Anaesthetists have released 2021 standards for the core standards for the pain management services. And there's a whole chapter dedicated to the pain management teams in that. So what does the team involve? The various bodies have consensus that the team should involve a physician, a physiotherapist, a psychologist or psychiatrist, and a nurse. These four components have been deemed necessary for the team. The IAS toolkit has left the physician options quite broad. What they have highlighted, the expert group has highlighted the core competencies which are necessary for if anybody wishes. And we'll look into these competencies shortly. The other mandatory components which are highlighted with the small asterisks here are psychologists, physiotherapists, and the nursing staff, and an officer. Now, there are some core competencies which this toolkit highlights, which every member should have, and that emphasizes most of the self-empowering aspects related to self-management, activity management, and providing guidance to the patient. So these skills every member of the MDT team should have. The toolkit also breaks down the subcomponent of individuals who are joining the team. And this is quite a comprehensive and a detailed and a busy slide. I don't expect you to read this, but the purpose of bringing it here was to highlight that the toolkit empowers the organization with these detailed ideas about what should be the desired specific skills, what should be the clinical skills, and what administrative tasks each member should be performing. For example, if somebody is looking to lead the pain service, for them it is mandatory to have 1 year training in another multidisciplinary center. Disciplines have been left quite broad again in terms of anesthesiology, palliative medicine, rehab. Similarly, if somebody is looking to become a psychologist to work with the pain team, they should have at least 3 months of training experience working with the patients in pain. And then there are certain subset of clinical and administrative responsibilities. It has been highlighted. So this toolkit is quite useful for anybody looking to employ or develop a new service to what they are exactly looking for. But one must keep in mind that achieving all these recommended mix of staff may take a lot of patience, a lot of willpower, a lot of flexibility to come out of the comfort zone. It also highlights the difference between a clinic and a center. Again, and this is quite a busy slide, but what I want to highlight here is that the center always has all 4 disciplines working in an interdisciplinary manner, like a clinician, a nurse, a psychologist, and a physiotherapist. And they will be mostly co-located and working in a coordinated manner with regular team meetings. Another big difference of a multidisciplinary pain center compared to a clinic is a continuous provision of education training to the healthcare providers. They also provide skills, and they are always providing research platform. And one of the other differences that group-based programs are there in the multidisciplinary pain center. The core standards for pain management in UK go one step further ahead by declaring that no practitioner acting in isolation, whatever their profession, can claim to run a pain management clinic or service. In other words, they're implying that whenever you run a pain service, it has to be multidisciplinary team work. This brings us to a big area in our part of the world, that how do we promote teamwork in our region, and what challenges do we face? Challenges are multifactorial. They can be related to the individuals, they can be related to the cultural barriers, healthcare beliefs, organization level barriers, and the barriers related to healthcare systems. We'll just go through each of them. So related to the individuals and the physicians themselves, their general lack of education and awareness and lack of interest. We do lack expertise in the biopsychosocial pain assessment. And generally, the culture of communication is lacking in our health professionals. As far as health culture is concerned, the multidisciplinary approach is less consistent with the patient expectations, because that is a long-term horizon. We look at quick fixes, quick reliefs, short-term horizons. So it is less consistent with what patient expects. And the outcomes also depend on patient participation, which culturally we may be a bit not so much adherent to. As a business venture, it is less profitable. Of course, interventions have more profit and industry backing. So that's why it has an overall lesser, smaller advocacy voice. There's overall lack of training in how to work as a team, because when we work as a team, it's not just about communication, it's about conflict resolution, it's about listening and feedback skills, it's problem solving skills, and how to support each other. Now, each of these components is rarely taught at undergraduate and postgraduate level. We generally lack the shared attitudes in our clinicians in terms of common agreed goals and shared mission objectives. When we look at a broader picture at healthcare system, and there's a lack of healthcare resources allocated by the government, pain is much lower down in agenda. In private sector, the story is totally different, because there's competing environment for the patient, and the healthcare working for fee for service act as a limiting factor to promote teamwork. There's lack of clearly defined standards of pain management protocols at national level. There's hierarchical work environment. At organizational level, there's lack of co-location in terms of physical space and time. Work demand is so high that there's no time to work in collaboration as a team. And there's a lack of general, stable, consistent workforce. So the trained specialists are a rarity as well. As a result, people are accessing the unqualified, unregistered practitioners. And in general, there is a lack of multidisciplinary pain centers in the country. How do we move forward? What are the recommendations? Well, they're quite broad again, but we have to bring them down to some discrete areas where we can start the journey. From bottom-up approach wise, we can start looking at the national policies where we prioritize pain, give a resource and finances to pain, which is a long way ahead further. We can work at developing national standards at guidelines to guide the other centers, and faculty of pain medicine in national level can do a lot of work in this context. In terms of training and education at undergraduate level, it should be the part of curriculum, and establishing a pain medicine as a specialty should be recognized by a national body. And there should be formal training related to teamwork at both postgraduate and undergraduate level. IS toolkit is quite good in that at each entry level, it describes a set of training which is required to enable us to work in a team. Again, that is quite a detailed document. It is available in the toolkit, free to download, so we can consult that. So overall, we need a complete paradigm shift in terms of culture. We need to promote a clear, direct communication between team members. We need to promote a culture to reduce the hierarchical work environment. In private sector, we need to reduce the competition for patients by engaging clinicians as employees by the organization or working as a larger group practices. we need to promote the collaborative approach in education, in quality improvement. It's all easier said, but where do we start? The IS task force recommends that we should work on promoting strong center of excellence as central hubs. They can act as a fulcrum for developing a national level MGT-based care model. Now, this center can then provide clinical training, mentoring service to facilitate development of other new services in the rest of the country and in the region. So the journey is quite long, and I'll close my talk with what our creator told us, that we are all working according to our own predispositions. We have our own skills, we have our own different strengths, different talents, different minds. And according to that, we are bringing different opportunities to influence each other. And it is in this diversity which makes us more strong, by uniting us and complementing each other through teamwork. It may take a lot of time and patience and willingness to be flexible and coming out of the comfort zone. But we should be open to challenges and start somewhere. Welcome all the question answers in Q&A sessions. Thank you very much.
Thank you very much, Dr. Usman. It was a wonderful presentation. We have one question for you, but we'll go to question answer session at the end of this. In the meantime, you can actually look at your question and prepare the answer for it. Our next speaker is Dr. Mohammad Ubadul. He is a consultant pain medicine in Marshfield Clinic Health System, USA. He's a graduate of 2006 from Allama Iqbal Medical College, Lahore. He's a board certified in neurology in 2016, and then he earned the board certification in pain medicine in 2018. So I welcome Dr. Mohammad Ubad, and here is his talk.
All right. Hello, everyone. My name is Mohammad Ubadul. I'm one of the interventional pain physicians at Marshfield Clinic in Wisconsin, United States of America. It's a great honor to be part of, this wonderful group and present something about interventional pain, and I feel very obliged. My brief background is that I did my graduation from Allama Iqbal Medical College, and then I did neurology, and then I did interventional pain. So currently I'm working at Marshfield Clinic. So my task is to go through the spine intervention in the cervical spine in 20 minutes. So I'll try to do my best, okay? So let's bear with me. This is the building where we practice. I do have disclosure about I'm holding some stocks in there. All right, so the objective of this talk is about learning the safety measures, learning and following the guidelines to perform the cervical spine procedures. And literally all the procedures we do, we have to follow the guidelines. So when I use the word guidelines, I try to follow Spine Intervention Society guidelines. They have a published version of that too. And again, in interventional pain or any surgical specialty, you need to know what you don't want to do, okay? So need to know the limits and boundaries. That's important. So when we talk about the cervical spine, why that is more special and more important than lumbar spine, and the reason is that the posterior epidural space, which is area of interest in almost more than half of the procedure we do, that space is only 0.4 millimeters comparing to lumbar spine, where it's almost 10 millimeters on an average. Other thing is that the ligamentum flavum, when we do the epidural injection, is not fused almost 50 to 70% of the cases in the cervical spine. And then look at the blood supply. The vascularity of the cervical spine and the neck area is abundant. So you need to be very familiar with the blood supply, what you are dealing with. So when I think about any spine procedures I do, especially cervical spine, I need to have imaging, and I prefer MRI. I want to review that imaging before I go in and do the procedure. I usually look at the T1 sagittal to look for the epidural space. I look at the axial cuts to look for any big vascular structures on my way. I make my own angles, and then I do the measurement. For cervical interlaminar or CSI, we need to not go above C6, C7. That is not recommended. So I usually stay at C7, T1, or even if I have to, I can go down to T1, T2 to treat the cervical radiculopathy. Because 1 cc of the solution which you inject should go 2 levels up and down. Then you need to get familiar with different contrast patterns to identify if this is the pattern which matches with the type of procedure we are doing. We need to take multiple views. Sedation is another important part of it. I don't do any procedures in general anesthesia. I probably will do some conscious sedation here and there, but I try to do it with very minimal sedation. So the patient can talk to me and tell me if my needle is in the wrong place. Let's talk about the CSI. As I talked about the MRI to be reviewed, I make my own measurement when I do it. I need continuous monitoring during the procedure. As far as the positioning goes, both of the upper extremities are hanging along the body, or we can do the swimmer's view if a patient is too big. Needle entry, I try to go slightly off midline, and the reason is that I like to do contralateral oblique for my epidural injections, and we'll talk about that. Other than regular fluoroscopy, I always do DSA or digital subtraction angiography to make sure I'm not in the blood vessel, especially for cervical spine. We talked about sedation. ESRA guidelines are very standard to follow for type of procedure you are doing. There's a very nice app which you should look into. It's worthwhile. It gives you all the low risk, medium risk, and high risk procedures and what medication patient is on, how long they have to hold, stuff like that. So I highly recommend that. For cervical epidural CSI, I use dexamethasone. Hardly I'll use any particulate like dapomedrol or Canalog. And one of the reasons is that there is documented cases about arachnoiditis happening from particulate steroid. These are few images to look at. So this is my needle entry. I line up the end plate pretty good. I go slightly off midline. That's my contralateral oblique. You are looking at the spinal laminar line right here. And that's where your epidural space is going to start. This is one of the procedures which I did. You can see a nice epidural space, and you can see how thin that line is. 1 or 2 millimeters, you go forward and you are in no-go zone. So that's a DSA. So on DSA, you are seeing basically there is no vascular spread. If there was any vascular spread, you would be able to see even a tiny vessel lining up very nicely. Some people do lateral image to confirm. I do that whenever I'm not 100% with my contralateral oblique. On that one, I've lined them the way they are. It's anterior longitudinal ligament, posterior longitudinal ligament. Then there's a spinal laminar line. So on the lateral view, that's where you need to be. Okay? So something to keep in mind. And that's the lateral view right there. That's the spinal laminar line we are talking about, and you can see the dye spread very nicely. So this is the quiz for you guys to look at. This is the lateral. What do you think, if it's deep or not, if it's appropriate? This is the ipsilateral oblique and the contralateral oblique. So this is a very nice view to master. Even in the bigger patients, you will not have any issues. But I will leave it up to you. Do your search and see if these needles placement are appropriate or not. Let's move on to cervical transformational. You need to have comprehensive understanding of the vascular structures, especially vertebral artery and all the feeding arteries into the spinal cord for this procedure. Excuse me. Again, review the MRI. I usually have my patients come and talk to me during a separate visit. I show them the images. I look at the sagittal and the axial cut. I want to measure the distance between the vertebral artery and the nerve root. And you'll be surprised that sometimes they're just hugging each other. And if you do the injection in that case without reviewing, that's the recipe of disaster. Again, DSA is must. I use small volume extension tubing with all of my cervical stuff so that the needle doesn't really move. I like to use 0.5 ml of 2% lidocaine as a test dose, wait for 15-20 seconds and see if there is any hemodynamic instability or the patient feels any metallic taste before I put the medication in. I only use non-particulate liquid steroid, which is dexamethasone for me. I also think that if the cervical transforaminal, you have been asked to do that, think about the less invasive options like cervical epidural interlaminar. If this is a tough patient based on the imaging, send it to interventional radiology with the CT guided procedures, okay? We talked about the sedation part of it, need to understand the flow pattern, contrast dye pattern, and this is something we need to reinforce it to each other. So we need to learn to say no to ourselves and to the patient sometimes. I know during some time there will be procedures you will not be able to go in the right place or you will have trouble doing it. You need to say no at some point. If I don't go into this epidural space or cervical transforaminal space in 2 or 3 tries and I'm getting the vesicular spread, I just call it a day off, okay? All the big risk factors are right there and complications which can happen. They are very well documented. I don't want to go through each of them, but just keep in mind. Contraindications, if somebody has contrast allergy up to the point of anaphylaxis, I will not do the cervical transforaminal. Infection, of course, in the procedural field. If the patient is uncooperative. Remember, when you are in the transforaminal space, you are literally a few millimeters away from all those vertebral artery, radicular artery, medullary arteries. So if the patient is not cooperative, you can just abort the procedure. So the positioning is important. If you look at this is the initial image. You want to do a PA view, goes caudal or cephalad to bring this uncinate process in one line. Just remember the theoretical vertical line drawing from uncinate process. You don't want to go beyond that, and we'll talk about that in a minute. This is the oblique view you want to see. You want to see the SAP lining up very nicely with the interlaminar line. And if you look, this is lamina, this is the SAP. You want them to be aligned. That means that when you hit the superior part of the SAP, you are not going too deep into the foramen. And I'll show you the next slide. So if you look here, you want to come oblique and caudal. If you think about the cervical foramen, usually they are funnel shaped and they are moving laterally and forward like that. So I know it's hard to imagine, but you don't want to come straight, oblique, because you can just go direct into the vertebral artery right there. So you want to come this way, you want to hit the SAP and put the dye and see where you are. That's a technique. I will just briefly touch it. Basically, you are aiming for the posterior 1/3 of the foramen, right at the level of SAP. And this is the magnified view. This is the needle. This is the foramen. You are in the posterior and inferior 1/3 of the foramen, and that's the SAP. That's the vertebral artery. The radicular artery is usually coming at the intermedial side of it, but the medullary arteries can be right in your way. So you have to be aware. This is the line that I was talking about, the uncinate process. If you draw a line straight down, and if you draw a straight line at the midpoint of the articular pillars, your needle needs to be in the mid of it. okay? You don't want to go beyond this line. Then you'll be either in the spinal cord or the thecal sac. There's again a DSA, just to make sure no vascular spread. I'll briefly touch on the stellate ganglion block. I mean, you can read all this, but usually that is done for complex regional pain syndrome. There are two views people like to do in the fluoro, AP view or oblique. I'd go with oblique view as I do my cervical transforaminal, and I tell you why. Now there's a new trend. Now they are actually advocating and encouraging people to do ultrasound guided stellate ganglion. And I get that. You see the vascular structure so well. But the downside is that you can't really see if you are in a small blood vessel. You know, you can, but you can't put the contrast and see. So it's all about your comfort level. So this is the oblique view as we did for cervical transforaminal. Our target is anterior tubercle of C6. You can see we are right in front of it. That's a DSA to make sure there is no blood vessel or vascular structure. And that's the washout after putting the medication. You can see it's lining up along the territory of the stellate ganglia. All right, so I will not go into the selection for the cervical medial branch. You probably guys all know very well. You need to recognize the patterns for the cervical facet joint related pain which can be referred. I don't know about practice in Pakistan or in the European countries, but here sometimes people just go with cervical epidurals. If there is no pain going below the shoulder, or if there is no good evidence on the MRI, I usually stay away from cervical epidurals. I mean, this is something which can be treated very well and with a long-lasting effect, okay? So if you look at the cervical medial branches, I just want to point out there is no C2 medial branch, okay? Usually that is a third occipital nerve which is formed from the C2 nerve root branch, okay? And then there is a C3, 4, 5, 6, and 7. Just keep in mind the location of C2 will be at the level of either just slightly above or below or at the level of C2, C3 joint. C3 is usually located at the superior part of the articular pillar of the C3, and so does the C7. All others are usually located like in the middle. So if you draw a cross like that, you would see that that's your area to be when you're doing the ablation. This is again the very various positioning of the cervical medial branches. So again, this procedure can be done in lateral and posterior position. I prefer posterior. It's more technical, but it's more safe. In order to do a lateral, patient is lying on the side and you want to get a perfect lateral. When we talked about the perfect lateral, vertebral bodies had to be aligned. You need to see the disc spaces very clearly. Transverse process should be in the upper part of the vertebral body, and the articular pillars needs to be aligned. So all these things, sometimes you can't do them. You really don't get that type of image on your fluoroscope, right? So when I started my fellowship, I was told that bone is your friend, and that is very true for most of the procedures we do in the spine. But here on the posterior view, I keep my needle right at the the midpoint of the articular pillar, and I touch the bone, and then in the contralateral oblique, I proceed further into that area, and I'll show you in a minute what I mean. Then I do the motor testing after confirming the position of the lateral, and then I put local anesthetic, and then we do the ablation. So that's one of my patients I did a couple of weeks ago. If you look, we are basically doing this is C2, this is 3, this is C4, 5, and 6. And you can see the articular pillar nicely. My needle is right at the midpoint right there. That's the contralateral oblique. This is my safety view. I want to see how far my needle is from the foramen. And you see when I'm going into this articular pillar on the contralateral oblique, on the lateral, my position is going to be right where I need to be. And I'll show you in a minute. So this is a very nice view. You should think about bringing it in practice. Here you see the articular pillar and my needle is right in the middle. So, all right, so next I'll just briefly talk about intra-articular Z joint. I don't do them very often. I prefer to do cervical medial branches and then go with the ablation. But if you are asked to do it, some people do in the lateral approach. I still try to do in the posterior approach, and I'll show you in a minute how I do it. So in the AP view, we do a caudal tilt, okay, and then you want a loosened joint space, and you keep your target at the subchondral bone plate of the SAP of the inferior level, okay? Needle touch the bone, and then you kind of walk into the joint. So that's, if this is the joint we are talking about, you want to be in the lateral 1/3 side of the joint, entering into the joint. And when you are about to enter, go contralateral axial C-arm rotation, that will help you. And as you can see, the contrast eye lining up nicely. All right, I think that's it for now. And luckily I finished on time. So I'll be ready for the questions. I hope I should be able to, share something useful for you guys. Thank you so much again for having me. I really appreciate it. Have a good one.
Thank you very much, Dr. Ubad. And our next speaker is Dr. Phillip Hu. Good morning, boss. Sorry for waking you up early in the morning. So I'm going to give an informal introduction of Dr. Phillip Hu. Dr. Phillip Hu, I've seen him first time in 2006 when he was delivering a talk in College of Anaesthetists of Ireland. And I was in Ireland for the few months only. I saw him and I became a fan of him, and I always wanted to be like him. He is the perfectionist. He is the best pain physician I have ever seen. He was my mentor as an anesthetist, and he was my supervisor in my pain medicine. And he also was my examiner as well. So now is the formal introduction. So Dr. Phillip, who is a pain medicine consultant and anesthesiologist in Tala University Hospital, Dublin, Ireland. He has done his graduation from Royal College of Surgeons of Ireland in 1997. He did his fellowship of anesthesiology from Royal College of Surgeons of Ireland in 2002. He did his pain medicine diploma in 2005, and then the fellowship in 2011 from College of Anesthesiologists of Ireland. He is a consultant anesthetist and pain medicine specialist since 2007 in Tala University Hospital. He has particular interest in spinal cord stimulation. And here we are with Dr. Phillip Hu, and we're going to see what he tells us about the advancements in the spinal cord stimulation. So up to you, over to you, Dr. Hu. Thank you very much for joining us today.
Good morning, everyone. My name is Dr. Phillip Hu, and I'm a pain management consultant from Dublin. I work at Tala University Hospital, and I'm very excited to be part of the Shaukat Khanum Cancer Symposium 2021. Firstly, I'd like to thank the organizers for inviting me to speak. It is truly an honor. Today, I would like to share with you some insights on neuromodulation in cancer pain. This is sunny Dublin, where I live. In pre-COVID times, if you had a conference, most likely it would be held at the convention center here in Spencer Dock. This is the River Liffey, and on a glorious sunny day, it bisects Dublin into the north and the south side. It has a nickname of being called the Coca-Cola can, and at night, when it's lit up with lights, it's quite beautiful. And when it's lit up in red, you can see why people would call it the Coca-Cola can. EFIC is having its conference next year in Dublin, and if you have a chance, do come and visit. In keeping with all international conferences, I have no conflicts of interest or disclosures to make at this point. My presentation today would look at neuromodulation, the definition, the concept of, and also the latest cancer pain management guidelines, most recently published. I would delve into, in more detail, intrathecal drug delivery and also spinal cord stimulation. Cancer is a painful condition. 35% of all cancer patients have moderate to severe pain. In advanced cancer patients, that figure is much higher, up to 80%. In terms of cancer patients presenting to the emergency department, 62% of them do so because of pain. In end-stage cancer patients, 68% of the pain is related to the primary tumor. 50% of patients, half of them, report significant pain from cancer treatments. And a third of patients have chronic pain after curative treatment. This is a significant number of patients. The International Neuromodulation Society defines neuromodulation as the alteration of nerve activity through targeted delivery of stimulus, usually an electrical stimulation or a chemical agent, to a specific neurological site to effect a specific action. The main two components of neuromodulation that I wish to speak on are intrathecal drug delivery and spinal cord stimulation. There are widespread applications for neuromodulation in chronic pain. We see them used in cancer and non-cancer situations. In other applications include movement disorders such as Parkinson's, where you can have deep brain stimulation. In epilepsy, also psychiatric disorders, patients with severe depression can benefit from vagal nerve stimulation. Stroke, brain injury, cardiovascular, gastrointestinal disorders, and also in bowel and bladder dysfunction using sacral nerve stimulation. It is imperative to speak of the opioid crisis if we are going to treat someone's pain. 500,000 patients have died from opioids between 1999 and 2019, according to figures from the CDC. It is important to keep in mind the opioid burden that this brings. I'm not aware of the figures in Pakistan, but it is a sizable problem in the Western world. The American Society of Pain and Neuroscience published this document in August 2021. It looks at the best practices and guidelines for the international management of cancer-associated pain. It is definitely worth the read, and a significant proportion of this presentation is from this article. One of the authors is a good friend of mine from Salt Lake City. In terms of guidelines for pharmacology, the WHO have issued guidelines in 2017, and also the European Association of Palliative Care Physicians. In terms of the international side of things, it's not so clear-cut, and that's why the ASPN in August 2021 published this document. The underlying principles are that there should be pain relief. We need to minimize the opioid burden where possible. We need to be cognizant of all the options that are available to us in terms of treating cancer pain. In terms of the WHO ladder for analgesics, opioid selection is important. Some of the considerations that might come into mind include renal dysfunction with patients with chronic kidney disease. Fentanyl is the opiate of choice as it does not have any active metabolites. A recent Cochrane review as well found that opioids are effective in treating cancer pain. In 19 out of 20 patients had a meaningful reduction in 14 days. However, 10 to 20% had to change the choice of agent or the therapy because of adverse events. We should not forget that there are multiple adjuncts available to us in terms of NMDA antagonists, such as methadone and ketamine. We can use serotonin modulation. There are bone modifying strategies, including radiotherapy, and also neurolytic blocks, which have been very effective, for example, in pancreatic cancer. In terms of targets for neuromodulation for cancer pain, they include peripheral nerve stimulation, the central nervous system, and the brain. I will focus on targeting the central nervous system through intrathecal drug delivery and spinal cord stimulation. In intrathecal drug delivery, a silicone catheter is passed into the intrathecal space. This catheter will then deliver a low concentration and low volume of the appropriate agent in close vicinity to the receptors and the target location, affecting the overall outcome. In spinal cord stimulation, there is a trial period, and epidural electrodes are placed percutaneously into the region where the dorsal column of the spinal cord is stimulated to in a number of various ways to modulate the pain signals. In terms of spinal cord stimulation, a huge amount of advances have happened in the last 5 to 10 years. We used to have only tonic stimulation, which is what we understand as paresthesia-based stimulation, where there's tingling in the area of pain. And this works by the gate theory of pain, and it has been effective before. However, it had many limitations. With the advent of high frequency stimulation at 10 kilohertz, we can now target axial pain much better. This works by supraspinal mechanisms as well as targeting the wide dynamic range neuron. Also, burst stimulation, which was discovered by Dirk de Ridder. It looks at both the medial as well as the lateral pathways of pain. The lateral pathways are the sensory discriminatory aspects of it, where you feel the pain, how hard is the pain, how sharp is the pain. Whereas the medial pathways look at the saliency of the pain, what the pain means, and how it's transferred onto suffering. Burst stimulation targets that, and it targets that very well. Over here, you can see that burst stimulation has pockets of 5 bursts of stimulation at 40 hertz. And this stimulates the spinal cord very close to the thalamic parameters. There are also newer targets such as the dorsal root ganglion, which is very effective for focal pain, for example, in the groin, following block dissection of lymph nodes, and also other stimulation parameters such as microburst and fast. In terms of intrathecal drug delivery, the Polyanalytic Consensus Conference published this document in 2017, looking at best practice and guidelines. In terms of intrathecal drug delivery, it is indicated if your oral morphine dosage exceeds 200 milligrams in 24 hours. This is done through a silicone catheter, again, that is placed in the intrathecal space. In our institution, we would trial patients first, usually with morphine, through a spinal as you know it, and monitor them for 4 to 6 hours. If they respond to the medication, then we can implant them with this pump, which is a gas-driven computerized pump. In terms of the practice of it, trialing is now becoming slightly controversial in that there are disadvantages to trialing. Some of our patients do not live very long, and trialing might be an added obstacle to receiving effective pain treatment. A lot of cancer patients would be on anticoagulation, and this would predispose them to both bleeding and also an increased risk of thromboembolic events, which are real if they were to stop it. In terms of the advantages of trialing is to see that you have a medication that will help them. So that it's worth doing. Intrathecal opioids have a limited focal spread, and this is very dependent on catheter location, injected velocity, the cardiac cycle, and other opioid properties. So in short, you have to be aware of the zone of pain that you're treating and to place your catheter in that region. For example, if it's visceral pain in the abdomen that you wish to treat, then the catheter must be placed at T5-6. This can be ascertained at the time of insertion. We can also use radioactive radiopaque dye that is injected through the catheter, and it will show you the spread. There are some considerations in terms of implantation of these devices in cancer patients. For example, there have been studies documenting no pump malfunction in patients who receive radiation therapy of up to 18 gray. In chemotherapy patients, it's also well tolerated. There is a issue about infection, and an absolute neutrophil count of greater than 500 should be maintained before the implantation of these devices. Granulomas can develop at the catheter tip, and when they do, they can cause irreversible neurological sequelae. So any patient who with an intrathecal catheter in situ who develops sudden neurological symptoms must have a scan to evaluate the catheter tip. In terms of agents that are employed in the intrathecal drug delivery, they are usually opioids. It can be combined with local anesthetic or baclofen, but baclofen is usually more employed in patients with significant spasticity from multiple sclerosis. Ziconotide, which is a marine snail toxin, has also been effectively used. It works by calcium channel antagonism. In terms of complications, bleeding occurs. We don't have any direct data for cancer patients, but extrapolated data from spinal cord stimulation patients, which show that 0.75% absolute risk of bleeding, and in cardiac patients of 2%. A lot of cancer patients will be considered immunosuppressed, depending on which phase of their journey they're in, and a lot of them will be on steroids. However, it's reassuring to know that the infection rate is 0.7 to 3% in these patients. Another consideration is MRI conditionality of these devices, and they would have conditionality for MRIs of 1.5 to 3 Teslas. The Polyanalytic Consensus Conference in 2017 looked at the choice of agents that should be used in these intrathecal drug delivery devices. The FDA approves morphine, ziconotide, and baclofen, which I said is mainly used in multiple sclerosis. Off-label usage is permitted. Agents that have been considered and used include bupivacaine, synthetic opioids such as fentanyl, sufentanil, and hydromorphone, and adjuncts such as clonidine. In terms of combinations of opioid and local anesthetic, the usual ratios are 1:2 or 1:3. This gives a good combination of mu antagonism and also blockade of sensory fibers without significant motor loss. The dosages of opioids that are used are considerably smaller than oral dosages, so it'll be 1:100, or epidural dosage 1:10. In these devices are now smart devices, and there is the ability to deliver demand doses that could be as much as 10% of the total daily dose. These are dependent on whether they are an inpatient or they're at home. Usually we start the infusion doses at 50% of what was their successful trialing dose. What about the evidence for its efficacy? This study was published by Lisa Stearns, who unfortunately isn't with us anymore. She did a meta-analysis of 1,355 patients with up to 12 months of follow-up. Their mean morphine equivalent dosages were 200 to 6,200 milligrams. So that's a significant dose. These were mainly patients with solid tumors and bone pain. She found that they had a statistically significant decrease in pain scores from 3 out of 10 on a 10-point scale, and the pain reduction was maintained for a year. There were no major safety concerns. Headaches, granuloma, posterior puncture headaches, CSF leaks, infection, all of these complications were between 0 to 6.8% in the studies that she looked at. This shows that it was a valuable alternative for intractable pain. We generally tend to implant patients who have a life expectancy of greater than 3 months. What about spinal cord stimulation? Cancer pain is mainly focused on the symptoms related to the primary disease. We should, however, also consider all treatments that can improve patients' quality of life. spinal cord stimulators are now also MRI conditional devices, and studies have shown that in all patients, 60 to 80% of them will require MRIs in 5 to 10 years. In a positive note, 5-year survival for cancer patients has risen from 50.3% to almost 70% in the last 20 years. Here's an interesting statistic. 52% of patients who are exposed to neurotoxic substances will develop chemotherapy-induced peripheral neuropathy. That's a sizable number of patients. This is amenable and has been treated with spinal cord stimulation. Other cancers in the abdomen, gynecological cancers and orthopedic cancers, thoracic tumors, they can go on to develop neuropathic pain and persistent post-surgical pain. Some patients can also develop complex regional pain syndrome. These are a number of references that have looked at the case series of patients who have developed these conditions, who have been effectively treated with spinal cord stimulation. So in conclusion, neuromodulation is a useful option in the treatment of cancer pain. It is very useful in intrathecal drug delivery with opioids, local anesthetic combinations for intractable cancer pain. It is reasonably safe and highly effective. Spinal cord stimulation can also be used increasingly now for survivors of cancer pains with neuropathic pain from either chemotherapy or from persistent surgical pain. They can also develop neuropathic pain in the form of complex regional pain syndrome, and this is all amenable to spinal cord stimulation, which has seen a huge advance in the last 5 to 10 years. At this point, I'd like to thank you for your time and your attention for my presentation. If there are any questions, you can contact me at philip.hu@th.ie. I hope you have a very fulfilling conference. Thank you.
Thank you, Dr. Phillip. It was a wonderful presentation as always. Our next speaker is Dr. Mohammad Kashif. He's a graduate from Pakistan in 2005 from Allama Iqbal. He did his FCPS in 2011 and then he moved to United Kingdom. He earned his fellowship in anesthesia and advanced training in pain medicine from Bolton. He is working as a consultant pain specialist and anesthesiologist in Royal Derby Hospital since 2018. I welcome Dr. Mohammad Kashif, and here we go with his presentation. Thank you.
Assalamu alaikum. My name is Mohammad Kashif, and I'm one of the consultants in chronic pain, currently based in UK at Royal Derby Hospital, and I will talk about neuropathic pain in cancer patients. So neuropathic pain, by definition, is pain which is caused by lesion or disease of somatosensory nervous system, which can be central nervous system or peripheral nervous system, and there are a number of causes for damage. There can be a number of causes for damage to the nervous tissue. So neuropathic pain in cancer patient, broadly speaking, is because of two reasons. One is from cancer itself, and the second reason is consequence of cancer treatment. So cancer-related pain is because of the direct invasion of the nervous tissue by the tumor. For example, it can lead to plexopathies, glossopharyngeal neuralgias, etc. And cancer treatment-related neuropathic pain, which is very common, can be because of the chronic post-surgical pain, which range from post-thoracotomy pain syndrome to pain after amputation, like stump pain, phantom pain, or it can be the consequence of nerve damage from chemotherapy and radiation therapy. So cancer survivors is a growing population of people because of the advancement in the cancer treatments. There are a lot of cancer survivors. Life expectancy has increased after cancer, and a majority of cancer survivors who have pain, majority of them, their pain is neuropathic in nature. Either it's because of the surgery-related nerve damage, radiation, chemotherapy-related nerve damage, or damage from the cancer itself. So neuropathic pain can come out of nowhere. It can be spontaneous, or it can be evoked. It can have positive or negative symptoms, and it can also involve a motor and autonomic nervous system. So for any neuropathic pain, our aim is to take thorough history, use screening tools, because no one or single clinical feature is diagnostic. So it has to be a combination of signs and symptoms before we label it as neuropathic pain. And like for any other neurological condition, our aim is to localize a lesion and find out the cause. So there are a number of screening tools. This one we commonly use in UK is called Leeds Assessment of Neuropathic Signs and Symptoms. It has two parts. One is the questionnaire for patients. Other one is for the clinician to do tests to rule out allodynia and hyperalgesia. Each question has a score, and if the maximum score is 24, if the score is more than 12, then patients are likely to have a neuropathic mechanism responsible for their pain. So for neuropathic pain, if we suspect neuropathic pain, we do confirmatory tests, which is one is the screening, see whether they have negative, positive signs in the innervation of a nerve, and then we do diagnostic tests and scans. If both are positive, then we say that they definitely have neuropathic pain. So the number of mechanisms underlying neuropathic pain they include peripheral central sensitization and phenotypic switching of peripheral nerve fibers. So peripheral sensitization involves lowering of threshold potential and expansion of receptive field, while central sensitization happens more centrally at the level of dorsal horn of spinal cord, where there is amplification of pain signals. Number of receptors are involved in this, and the most notable receptor is NMDA receptor. Phenotypic switching means the nerve fibers which are not normally carrying painful sensation, they start conducting non-painful signals as painful. So I'll spend a few slides on chemotherapy-induced peripheral neuropathic pain, as this is very common in cancer patients and it's very challenging to treat. It's basically a side effect of chemotherapeutic agents, which depends on the type of agent we're using, the duration, and the combination. The most common culprits are these: platinum compounds, taxanes, vinca alkaloids, etc. So basically what happens is these agents, they cause damage to neural structures, microtubules, axons of DRG, myelin sheath, and sporting glial structures. These agents, they mainly cause peripheral neuropathy, not central, because they cannot cross blood-brain barrier, and peripheral neural structures have poor blood-brain barrier. They predominantly affect small fibers. That's why most of these patients represent with burning sensation and loss of temperature sensation. Like diabetic neuropathy, they also present this neuropathic condition also present in glove and stocking distribution, but it's predominantly sensory, unlike diabetic neuropathy, except in oxaloplatin associated neuropathy, where there is motor involvement as well. So number of agents have been studied, and there are a lot of studies about what agent we can use with chemotherapy to prevent this peripheral neuropathic condition. Out of these, there's no conclusive evidence for any one of these, but most of them, the concept behind them is that is the use of antioxidant agent. So treatment of any neuropathic condition consists of treating the underlying cause. For example, if there's cancer and we can do surgery and remove the tumor from the nerve, that may or may not resolve the issue. Unfortunately, it's not always possible, and the mainstay of treatment remains pharmacological. There are some interventions which we can perform, and then pain management should be part and parcel of any treatment regime. So before we discuss pharmacology of antineuropathic agent, I just want to spend a minute on pain pathways and pain modulation. So just a bit of a revision of physiology. So pain pathway involves primary efferent neuron synapsing in the dorsal horn, and then the second order neuron arise and cross over to the opposite side and ascend in lateral spinal thalamic tract to thalamus, and from thalamus, the third order neurons go to somatosensory cortex. So this is ascending pain pathway. Now there are some descending pain pathways as well, which descend from higher center, mainly midbrain, to the dorsal horn of spinal cord. So there are two kinds of descending pain pathways. One is inhibitory, and the other one is facilitatory. So facilitatory pain pathways amplify pain, and they use neurotransmitter serotonin. And the inhibitory pain pathways, they inhibit pain transmission at the level of dorsal horn, and they use noradrenaline as a neurotransmitter. So these pathways are the target for antineuropathic medications. So there are a number of antineuropathic medications. We can use any one of them as first line, the other one as a second line. Third line agents are usually topical agents and opioids, and then cannabinoids potentially have a role in neuropathic pain, but they're not licensed for use for neuropathic pain in UK yet. So they can only be used as part of clinical trial, but cannot be prescribed for regular use. This is because the studies so far have failed to conclusively give evidence that their risk is less than their benefit. So tricyclics and SNRIs, they have lowest NNT of all antineuropathic agents, but they're not free of side effects. They cause a lot of side effects. So their main mechanism is that they inhibit the reuptake of noradrenaline, so increase the noradrenaline level in the nervous tissue, which is the neurotransmitter used by descending inhibitory pain pathways. Unfortunately, they also act on a number of other receptors, including acetylcholine, 5-HT2, 5-HT3, and so forth and so on. So they cause, the range of side effects. Gabapentinoids include drugs like gabapentin and pregabalin. They inhibit calcium channels, alpha to delta subunit of calcium channels, and modulate neurotransmitter release. So again, they are not free of side effects, especially for frail cancer patients. They struggle to tolerate these medications. The other problem with gabapentinoids is the potential for misuse and abuse because they cause kind of a high feeling. So they should not be used for anything other than neuropathic pain, and we should try avoid using them left, right, and center. So topical agents, the advantage with topical agents is that they have minimal systemic side effects, so they're relatively safe to use. Their main utility is in the allodynia, the skin sensitivity associated with neuropathic pain. So this was lidocaine plaster, which mainly acts by sodium channel blocker in the local nerve endings. The other local antineuropathic agent is capsaicin, which basically stimulates the nerve fibers, pain nerve fibers. It acts on TRP1 receptors and stimulate pain nerve fibers, cause them to release their neurotransmitter and cause severe burning sensation, basically C fibers. So the idea is to stimulate pain fibers so much that they deplete, they release all their neurotransmitter, and then they cannot conduct the pain impulse anymore. So again, they reduce the area of allodynia with repeated application. They're applied for 60 minutes every 3 months, but they cause severe burning when they're applied. The other problem with them is their cost. They are quite expensive. One patch is around 220 pounds in UK. So opioids, there are a number of opioids, strong opioids and dual action opioids like tramadol. So tramadol has opioid action and antineuropathic action because it inhibits reuptake of serotonin and noradrenaline. And these neurotransmitters are used in descending pain pathways. So this is where its utility lies in neuropathic pain. So tapentadol is probably a bit better than tramadol because it blocks the reuptake of only noradrenaline, and noradrenaline is the neurotransmitter utilized by descending inhibitory pathway. Serotonin is utilized by descending facilitatory pathway. So maybe it's potentially, theoretically speaking, is better than tramadol, and its side effect profile is better than other opioids, but its cost is a bit higher than the tramadol. So interventions for cancer-related neuropathic pain range from surgery, intrathecal neurolysis, spinal cord stimulator, to percutaneous cordotomy. So for spinal cord stimulator is mainly used for non-cancer neuropathic pain, but it has its potential and utility for cancer survivors. And there are ongoing studies for its role in cancer survivors. Same goes with intrathecal opioids. Transcranial magnetic stimulation is a non-invasive technique where we apply magnetic field on motor cortex. It has been used for psychiatric problems, refractory depression, etc., but it also has its role in neuropathic pain, and there are studies ongoing for this. The technique which I want to discuss is percutaneous cervical cordotomy. It's a very effective procedure for cancer pain, especially for people who are, suffering from terminal cancer pain. So basically, cordotomy is disrupting the spinothalamic tract fibers in the cervical spinal cord at C1, C2 level using radiofrequency current. This can be done surgically as well, and the first surgical cordotomy was done in 1912. So basically, what it does is it reduces pain and temperature sensation in opposite half of the body. So cordotomy can be done for any unilateral cancer pain below C4 dermatome, whether it's lung cancer, breast cancer, unilateral leg pain, etc. It's effective for both nociceptive and neuropathic pain. The strong indication, one of the strongest indication for cordotomy is mesothelioma related pain. And mesothelioma framework group recommended its use for all the patients with mesothelioma who have severe pain. But it can also be used for severe form of sarcomas, bone cancers, because these patients have very severe incident pain which does not get relieved with any sort of opioids. But cordotomy can do miracle for these patients. So how do we do cordotomy? Basically, the patient lies supine, and this is a lateral X-ray of cervical spine. This is C1 and C2. Between C1 and C2, we insert a spinal needle. Aim is to do a dural puncture at this level. Once we are in the thecal sac, then we inject contrast, and we see 3 lines. This is posterior dural sac, and this is anterior dural sac, and this line is dentate line, which basically indicates the dentate ligament, which is a reflection of dura, and it's attached to the equator of spinal cord. Since spinothalamic tract lies in the anterolateral quadrant of spinal cord, so our aim is to insert needle just above this dentate line. So once in the spinal cord, then we do sensory and motor testing to make sure that we are in the spinothalamic tract and not in any motor tract. Typically, patient complains of burning sensation. The center of spinothalamic tract has representation of hand, so they should ideally complain of burning sensation in their opposite hand. With this feedback, we are sure that the needle is in the right place, and then we create a lesion at maximum 85 degrees centigrade. Most of the patients poorly tolerate this temperature, so we start at 65 for 30 seconds and gradually ramp up the temperature. And then most of the patients, then they say that they have loss of temperature, and typically they say they have no pain immediately after the procedure. So there are a number of outcome studies. In one such case series, they studied 125 patients, and they said that more than 90% of the patients had good pain relief. So this is our case review from Walton Center, where I was trained. So these 2 lines, they represent pain scores. The blue one is maximum pain, and red one is average pain. So this is before cordotomy. Immediately after cordotomy, the pain score goes right down to close to 0, less than 10. And it stays like this. We studied it up to 28 days, but well beyond 28 days. Yes, potentially speaking, there can be a lot of drastic complications. Don't forget that the size of cervical spinal cord is equivalent to the little finger of the person. And we're creating a small lesion in one part of the little finger. So there's chance that we may not get our needle in the right place. In that case, we just abandon the procedure, so failure. From unknown mechanisms, some patients complain of mirror pain, like same pain in the same area, but on the opposite side of the body. Usually it's not very severe and it's self-limiting. If we damage respiratory fibers or autonomic fibers, that can be problematic. So there's a term called Ondine curse when people stop breathing when they're sleeping. This is because damage to respiratory fibers, the automaticity of breathing is lost. Then, of course, there's risk of paralysis if we fry the corticospinal tract. And risk of deaths, we normally say around 1%, but in one case series, they said they reported 1 death in 600 cases. So it's probably less than 1%, but we still say 1%. So one must not forget that the patient at the other end of the needle is a human being who's suffering from cancer's end of their life. So they have psychological issues. They're bound to have psychological issues, social issues, financial issues. So any management of any cancer patient is incomplete without the involvement of multidisciplinary team. So there has to be involvement of psychologists, physiotherapists, pain nurses, occupational therapists. So basically, the concept of pain management is different from pain relief. So pain relief is if we give somebody an injection or a tablet and then we expect that their pain will go away, which is not always the case, especially in cancer patients. If we cannot relieve somebody's pain, then we should try to rehabilitate them and try to help improve their quality of life with pain. So the aim of pain management is to reduce impact of pain on mood, sleep, and function. And I think all cancer patients, they need a degree of pain management. So we should stick to this teamwork approach. So this is a pyramid of modern approaches to cancer. So yes, we have anti-cancer treatments, we have surgery, interventional techniques, analgesics, and pain management-based approach. But all these should be applied together, should be used in tandem. If we're using analgesics, we should not forget that there is option of pain management, or if we're using intervention, we should not, forget the analgesics and pain management. All these, when applied together, they result in better outcome and better quality of life for cancer patients. I think I am well within 20 minutes. So this is the list of references. Thank you very much.
Thank you very much, Dr. Kashif. Our next speaker is Dr. Professor Gohar Afshan. She is a consultant anesthetist and pain medicine consultant in Aga Khan University Hospital, Karachi. She is a graduate of Dow Medical College, Karachi, and has done her FCPS in anesthesiology in 1996. She did her pain fellowship from Queen's Medical University, Nottingham, United Kingdom. She is an endowed professor of anesthesia and pain medicine and a former chair of the Department of Anesthesiology at Aga Khan University Hospital, Pakistan. Her passion for relieving patients' pain shaped her path towards pain medicine. She established first pain setup at AKU, followed by the first pain fellowship program in Pakistan. She is a member of Pain Management Committee, WFSA, Cancer Pain Guideline Committee, WHO, and Secretary and Faculty of Anesthesia in College of Physicians and Surgeons, Pakistan. She is the recipient of many national and international grants and author of more than 100 peer-reviewed publications. So I welcome here Dr. Gohar Afshan, and let's move on to her talk. Thank you very much.
Bismillahirrahmanirrahim. First of all, I would like to thank Organizing Committee, 20th Shaukat Khanum Cancer Symposium for this invitation. And I'm very special thanks to Dr. Rahman, who chose the topic, which is very, very, very relevant in the current pain practice. So the topic of my presentation is intervention pain management in cancer and palliative care ethical concerns. I am Dr. Gohar Afshan. I am Tajuddin Hussain Jafar, Endowed Professor of Anesthesia and Pain Medicine, Department of Anesthesiology, Aga Khan University, Karachi, Pakistan. So first of all, I would like to give some disclosure. I have no financial disclosure, although considering the topic of today's my presentation, I would just like to tell that I am a member of WHO Guidelines Committee for Cancer and or certainly and also palliative care, and a member of the Pain Management WFSA, which is World Federation Society of Anesthesiology. This is my plan for today's presentation. I would first like to talk about pain burden in cancer and palliative care. Then I will talk about IPM, the basic principles of ethics. This is very important in context of the IPM. What are the ethical challenges as a pain physicians we are facing? What are the complications of common IPM and the cost incurred? Again, that's an ethical issue, and I would like to summarize at the end. So pain burden in cancer and palliative care. So we all know cancers are among the leading cause of morbidity and mortality. A significant number of cancer patients suffer from pain caused by disease or its treatment. Pain is experienced in 55% of patients receiving anti-cancer treatment and 66% of patients with advanced stages of cancer and palliative care. Unfortunately, in low and middle income countries, approximately 80% of the cancer patients experience moderate to severe pain due to non-availability of the common pain treatment modalities. We all know the goal of the cancer pain management is to relieve pain to a level that allows acceptable quality of life in a patient who is suffering from pain and end stage of life. Numerous country need assessment, a recent WHO consultation report, the multiple national and international surveys, and the two human rights report. They all highlighted that the pain, cancer pain especially, is undertreated. And approximately 5.5 million people worldwide receive no or minimal treatment for their cancer pain. So we can imagine how prevalent this untreated pain is. Now, this estimate of undertreatment of pain is based on a series of assumptions and existing epidemiological data. The reality is that the epidemiology of cancer is not fully understood, not fully known. And because of the lack of tumor registry, the lack of statistical information, particularly in resource-limited countries, we have no idea about that. Epidemiological studies suggest that the prevalence of cancer and the palliative pain is increasing, especially in LMIC. So with this small background and the current literature available, no doubt the pain in the cancer and palliative care is a major medical and economical problem, a huge burden to the society. So recently, I fortunately work in WHO Guideline Committee, and this is the most recent WHO Guidelines Committee for cancer pain in adults and adolescents. We all know the therapeutic options of the pain management in cancer and palliative care. The cancer pain is usually managed using conventional pain medications, simple analgesics, and opioids and adjuncts as advised by the WHO step ladder, which is highly practiced in different parts of the world. However, pain relief is suboptimal in a cohort of patients because of either ineffectiveness of conventional systemic analgesia or undesirable side effect associated with these common medication used in cancer and palliative care patients. Approximately 10% of patients continues to have severe pain and or experience poor quality of life from the drug adverse effects. Certainly, these patients could benefit for another option of the treatment, which is IPM, the interventional pain management. I will talk about in the few next slides, but just briefly, the IPM is small nerve block to a very fancy procedure like percutaneous scudotomy. So interventional pain management is a range of intervention we're talking about. That small single nerve block injection to the intrathecal nerve system to the percutaneous scudotomy. When be interventional treatment considered? That's a very important question for any pain physician. So the only two conditions actually is you have to rationalize. For unrelieved or refractory pain, if you think that you have tried everything and patient's pain is not relieved, the quality of life is getting better, worse and worse, or adverse effect of pain medication, the patient's pain are settled, but because of the adverse effect, patient is not, acceptable quality of life. So IPM, the interventional pain management, it is defined as a discipline of medicine devoted to the diagnosis and the treatment of pain-related disorder, principally with the application of interventions technique independently or in conjunction with the other treatment modalities. This is a new specialty, and the history is just not more than 2 decades. It has gained rapid development over the last 2 decades, and according to the recent Medicare database, there is a 179% increase of IPM. 189% increase in IPM, you can imagine. So IPM showed a continued and significant increase in fee-for-service Medicare beneficiaries from 2000 to 2014, यानी कि 2000 से 2014 के दरमियान बहुत ज़्यादा increase हुआ है, and this is about 153 per 100,000 Medicare population, significant number. Although these numbers are more relevant in the country like America, where the health system is basically driven by the insurance company, but certainly we have to know about the problem. So what is ethics? I know any physicians who is practicing here, they know the basic principles of ethics, but basically ethics is right versus wrong conduct. Ethics is what constitute a good or bad. That's a basic, we have in your mind what is ethics is. We also very well aware about the 5 principles of ethics: autonomy, beneficence, confidentiality, don't harm and non-maleficence, and equity and justice. A very brief about few words about autonomy. So autonomy is in medicine is simply allowing patients to make their own decisions. Physicians have an obligation to create the condition, the environment necessary for autonomous choice in others. For a physician, respect of autonomy includes respecting an individual's right to self-determination, as well as creating the condition necessary for autonomous choice. And this is very, very important. This is your role is create that kind of environment. The principles of beneficence, again, another very important principle, is the healthcare providers have a duty to be of a benefit to patient, as well as take positive steps to prevent and remove harm from the patient. So these duties are viewed as rational and self-evident, and are widely accepted as the proper goal of medicine. So हम काम करते हैं beneficence के लिए. That's very important. So non-maleficence, we must know about this very clearly. The principle of non-maleficence requires of us that we not intentionally create a harm or injury to the patient, either through act of commission or omission. And this is again important. The principle affirms the need of medical competence. I know what I can do that, where I am competent enough. It is clear that medical mistakes may occur. Even an experienced person, well-known physicians, they can make a mistake. However, the principle articulates a fundamental commitment on the part of healthcare professionals to protect the patients from harm. Okay, so this is very, very important. Now, what are the ethical challenges in the IPM practice we as if pain physicians are facing or might face? What is right and how do we do it? This is a very important question of this current stage in evolving discipline of pain medicine. Ethical issues like integrity and altruism are common. Commitment to quality is central to the ethical practice. We all know that. Everyday pain physicians can grapple with the ethical issues: integrity, truth-telling, doing goods, avoiding harm, altruism, and humanism. Practice they all know that. So intervention pain procedures, they have changed the face of pain medicine. We all know that this is benefit, benefit. Although we are concerned with the ethics attached with that, but there are many benefits, especially for long-term pains, the chronic cancer, and palliative care. But they have some ethical issues. IPM is highly dependent on expensive technology, especially equipment related, and has witnessed rapid evolution and rising cost, because jitna aapki intervention advance hogi, utni cost bhi uske saath judegi. Now, because of these technological costs, there's a huge economical impact with increasing prevalence of chronic pain. हमारे टाइप के मुल्कों में बहुत ज़्यादा एक पेशेंट के अपनी फैमिली पर बर्डन हो जाता है या गवर्नमेंट के इंस्टीट्यूशन पे हो जाता है because insurance company are बहुत यहाँ पे कम है, but this is really a concern. So the rapid development of IPM raises several very, very important issues, and I would like your attention towards this. Assurance of professional competence and technical support, and this is very important when IPM is being practiced anywhere. Self-referral and the relative role of your peers. किसको पता है कि भी she is the person जो ये काम कर सकता है, और या मैं सिर्फ दोस्ती यारी में अपनी पेशेंट यहाँ वहाँ भेजूँ. No, we have to be very, very professional कि हमें किस कॉम्पिटेंसी देखते हुए कहाँ रेफरल भेजने. कॉस्ट ऑफ हेल्थ केयर एंड इमेजिंग रिक्वायर्ड, ये आपको पता है जितना जितना एडवांस ट्रीटमेंट ऑप्शन होंगे उतना उतना आपको कॉस्ट बेयर करनी पड़ेगी. एंड वेरी इंपॉर्टेंट इज द कॉन्फ्लिक्ट ऑफ इंटरेस्ट, जिसमें भी थोड़ी देर में बात करूंगी. Now these questions are properly addressed within the framework of medical ethics. है ना, कैसे रेफरल भेजने चाहिए, कॉन्फ्लिक्ट ऑफ इंटरेस्ट को एड्रेस किया नहीं किया है, and that's around you have to practice around the principles of beneficence, autonomy, justice, and things like that. There are many areas in which there can be conflict between the patient's own interest, your best interest, the physician's own interest. The patient's best interest and physician's own interest, ये वाली combination सबसे खतरनाक है. Because if the interest is not the same, then there's a problem. So patient's best interest वही होना चाहिए या patient जो physician's का own interest. ठीक है? So the major ethical concern is the ownership interest will lead to inappropriate utilization exemplified by poorly indicated or unnecessary procedures. ये जो बहुत सारी बातें हो रही हैं इंटरवेंशनल फिजिशियंस के लिए, वो चाहे पेन के हों और कार्डियोलॉजी के हों और गैस्ट्रोएंटरोलॉजी के हों, unnecessary procedure should not be done. That's a major issue because the physician's own interest certainly, unfortunately, भी कहना चाहिए, is a remuneration. So if I need money and money comes mainly from the intervention, so I would like to do intervention procedures, and I may make some kind of a justification why I'm doing this one. But basically, if you're considering the basic principles of ethics, certainly not all patients' indication is as per evidence-based medicine. So this is very important. Third-party payer की मैं ज़्यादा यहाँ नहीं बात करी. In Pakistan, there may be third-party payers. इंश्योरेंस कंपनी भी होती है, हॉस्पिटल एडमिनिस्ट्रेशन भी होती है, बट सर्टेनली द कॉन्फ्लिक्ट ऑफ इंटरेस्ट मेनली जो डिसीजन मेकिंग ऑफ द टू, द डॉक्टर पेशेंट रिलेशनशिप, व्हाट इज द बेस्ट फॉर द पेशेंट, व्हाट इज माय ओन इंटरेस्ट, दैट शुड कॉन्फ्लिक्ट नहीं होना चाहिए. सो बाय द नेचर द इंटरवेंशन प्रोसीजर कैरी रिस्क, कॉम्प्लिकेशंस फ्रॉम द प्रोसीजर, we all know that. ठीक है, results will lead to physician to the wrong diagnostic conclusion अगर मैंने procedure ठीक नहीं किया है and that procedure is for the diagnostic purpose, certainly I may mislead the patient. And the subjective nature of the pain is a major problem for pain management. We all know that. Complications may be minimized by performing procedures in the safest environment possible. These are prerequisites where to do what procedures with most up-to-date equipment and by the experienced, highly trained person. It's not that आपने सिर्फ एक दफा देखा जो आजकल रिवाज हो गया है YouTube पे and then start doing procedures. These procedures should be practiced or should be done after having a reasonably practiced in the supervised environment. Good qualification hai, good training slots hai. So this is not like a one-time ek dafa dekha ek dafa laga de. That's not the kind of procedures. Multiple factors not under the direct control of the physicians or patients, such as third-party reimbursement, they may have influence on such important safety factors such as where and by whom pain procedures are performed. Physical location की मैंने बात की. So whenever I decide that I want to do this procedure, then I have to see what requirements that procedure, if I want a good outcome, safe, सब कुछ ठीक हो, effective हो. Certainly there's some checklist कि ये होना चाहिए. So physical location is one of them. कहाँ होगा ये? Is it the outpatient procedure or patient को किसी अंदर safe environment में लाके करना है? Theater में करना, imaging required. And all these things जो है ये बहुत से ethical issue खड़ा करते हैं. If you have, if even in sometimes the minimal invasive procedure required, that procedure should not be done as an outpatient clinic. Now there are again the conflict of interest. Maybe my very hi-fi operating theaters are not being utilized and they are available, they are vacant, and I want the procedure as an administrator of the hospital, I want that theater to be utilized. Certainly, I might push my physicians to do these procedures in the theater, but that's not good for the patient because this procedure can be done in outpatient. And because I want to utilize as an administrator this very fancy theater, so I will bring that patient to the ward. Itna bada bill ban jayega, or that's not. Similarly, that's insurance company have pushed that the procedure should not be done in an inpatient setup. बड़ा महंगा पड़ जाता है और imaging बड़ी महंगी होती है. And that pressure, you bring that patient to the outpatient clinic or safety compromise करें वो patient जो कि it has to be under the all imaging and operating theater, safe environment में अपनाना. So both are very bad in terms of the patient's interest. Lihaza, the physical location IPM without any pressure of hospital administration, insurance company A, B, C, D, you have to justify where that's the best place. Procedure in outpatient clinic, the cost of supply we all know certainly कम होती है as compared to अंदर, तो इसमें बहुत basic फर्क पता चल जाता है. Some insurance program they move procedure out of more expensive setting. उनका अपना concern होता है, site of the service differentiated. As a physician आपने decide करना है. Don't take that kind of pressure A, B और C का कि आप patient का interest भूलें. The best interest हमें जो काम करने patient के interest में काम करना. We all know that the patient's vulnerability, especially the cancer and palliative care patients, they are extremely vulnerable. And he or she, whoever is suffering from, they actually rely on the providers for continuing treatment from the physicians. तो बेचारे वो बहुत बातें यही कहते रहते हैं, जितना भी हमारे एक्सपीरियंस है, डॉक्टर साहब आप जो समझते हैं, डॉक्टर साहब आप बेहतर समझते हैं, डॉक्टर साहब हमारा बस आप एक काम पहले कर दें, this kind of a thing. A primary goal is the relief of suffering and restoration of function. We all know that कि हम सिर्फ pain का number wise pain नहीं ठीक करना चाहते कि pain कह दिया जब 10 से 6 हो गए, नहीं. We also want कि patient अपने कुछ काम काज, अपनी कोई लाइफ में चलना फिरना, खुद वॉशरूम जाना, so restoration of basic function वो उसके resume हो जाए. Pain, we all know, is subjective in nature, and one of the greatest limitation of pain is a lack of objective diagnostic tests that identify the quantify pain, कि कितना pain है, बहुत ज़्यादा है, कम है, क्या है. Use of IPM to diagnose and treat pain involves ethical concerns of beneficence and non-maleficence, as well as the potential financial conflict of interest, जिस पे मैंने भी बात की. Third party payer की भी हमने बात की है. Then again, this is very important. You as a physician, you have to decide IPM कब करना है, कैसे करना है, कहाँ करना है. आपके पास safe environment किसको define करेंगे, and all these things. In the pain management, the patient vulnerability is a prominent feature of the doctor-patient relationship. Correction, intentional or otherwise, is an ever-present possibility. So here I would just like to actually summarize or conclude that IPM, intervention pain management techniques, like other medical treatment, or जहाँ पे और जगहों पे भी intervention आ रही हो, cardiology हो, gastroenterology हो, so they continue to evolve. So लिहाजा pain में भी evolve होंगे. We cannot stop कि आप यहाँ पे आकर रुक जाएंगे. Ethical challenges in the IPM, when what intervention is the best for refractory pain, is a real challenge for pain physicians. Certainly we have guidelines, we need more guidelines, more rational guidelines, but still we need to do more and more in this area. It should be practiced, we all agreed, it should practice in evidence-based. Okay? We should not forget the basic ethical principles whenever we're trying to offer any procedure to anyone. ठीक है, ये बहुत important है. Patient autonomy का आपने ख्याल रखना है, beneficence को harm तो नहीं दे सकते, your competencies क्या है, आप कैसे justify कर रहे हैं. We must ensure the safe and standard quality intervention treatment in this part of the world. LMC जहाँ पे बहुत ज़्यादा ये बीमारियाँ बढ़ रही हैं, there are a lot of patients coming up for these kind of procedures. The final truth is that there is any question as to the safety of the procedure, one should not consider the procedure. And this is a basic चीज. अगर आप फायदा नहीं पहुंचा सकते तो harm तो बिल्कुल भी नहीं करना चाहिए. So लिहाजा you have to see this very important angle कि आप कैसे इस procedure के outcome को देख रहे हैं. The failure to recognize the ethical principles can give the bad reputation to this evolving specialty. As a pain physician, मैं इस specialty के नाम की बदनामी मेरा दिल दुखता है. Certainly, if there are people who are doing good practice, there are people who practices are not as per the evidences, as per the standard practice. So certainly the specialty badnaam. So this is very, very important for all of you understand that IPM कोई नहीं रोक सकता. It is a evolving specialty. But the ethical concern attached with this intervention, we have to be very careful. And thank you very much for this very important topic, Dr. P again, and the organizing committee. And my very best wishes for a successful 20th Shaukat Khanum Symposium, the Cancer Symposium. Thank you very much.
Thank you, Dr. Gohar Afshan. We'll start now the questions. So far, I have received 4 questions, and 2 questions are by Dr. Azhar Rahman. So the first question he has asked from Dr. Usman Bashir. He says, we have qualified pain physicians in very few centers. How can we overcome the shortage of pain physician in public sector where pain management is not a priority? So anyone can answer, but he particularly asked from Dr. Usman Bashir, and all of you are also welcome to join answering this question. I think this is a very hot topic to discuss.
Thank you very much, Dr. Azhar. That's a very, very relevant question. Can you all hear me?
Yes. Yes, Usman.
Yes, that's good. I think your question is so broad that it needs multiple tiers of approach. But we, like as a nation, as organizations, as each hospital have to decide a starting point. Of course, you need the approach at individual level, at organizations level, and at the college or a national body level to start a nationally recognized program. The efforts have been started. The specialty of pain medicine is already has started officially by CPSP. The issue lies that how do we spread it nationwide, like you have asked, that in public sector hospitals. So at first, the pain has to be high up in the agenda of government. There has to be a voice of the pain physicians heard nationally that it needs to come in the public sector domain. There are hardly like 3 or 4 centers nationwide which are providing good services related to pain, but the population needs are not at all fulfilled by that. So again, there can be various tiers of those raising that voice, like in form of a visible campaigns, which are quite visible, not just snapshot of small conferences, but I'm talking about campaigns the way Shaukat Khanum runs their breast cancer campaign. So you need funding for that to make pain awareness visible as to public. Then they will know it's their right. And then they will ask for the right specialist to treat their pain. While we get there, it's a time-consuming process, of course. It will take time, it will take patience. But we do have a lot of resources now for which we don't have to invest anything. Look at internet, look at Zoom, look at what COVID has brought us, like we are all together sitting here doing this excellent conference. So there are a lot of resources of pain education available. IS, the way they have released their toolkit, they have 3 levels, 3 tiers of training. And everybody can have that foundation level training. You don't need any investment for that. It's just a willingness to proceed. But we do need some structure to that willingness to proceed, that how a sustainable culture can be maintained. And for that, I think we need approach at the organizational or bigger levels. So it's both spectrums have to be dealt with at each end. And I'm afraid answer is not simple, working in the cultural values over here. But we do see from the local studies, the way we saw from Atikur Rahman's study yesterday, that pain not only has physical impacts, but even in our culture, it has psychological impacts. So this notion that we are different from Western culture, we don't have health-related quality of life issues is not right. Medico Dosa study also showed the same as well. So there is a need to develop good multidisciplinary centers with the likes of like Aga Khan, Shaukat Khanum, and few others to name it. And from these centers, other centers can send their trainees to get some initial training and move on from there. So I'm sorry, the answer is quite long and quite broad, just like your question. So we can leave it for debate amongst all of our eminent panelists here who are working abroad, Dr. Gaurav Shah, Dr. Atik, Dr. Khalid Bashir, Brigadier Salim, our pioneer, they've all been doing such a great job in the limited resources which are available here. So which means that we have a lot of scope. It's how to give direction to these very useful resources is the big question. Thank you.
Thank you very much, Usman. And I would like to take advantage of advertising the fellowship post of pain medicine in Shaukat Khanum. So we have 2 posts available for fellowship in pain medicine. It has been advertised, but nobody has actually yet applied for it. So on this forum, I'm doing the advertisement for all those who are interested. You can join us. Right. So next we'll move on to the other question by the same doctor. He says, do you think that near future, are we going to shift to ultrasound rather than X-ray for cervical spine procedures? So I suppose this is for Dr. Ubaid. Dr. Ubaid, are you there?
Yes, I'm here. Everybody can hear me?
Yeah.
All right. Yeah, that's a great question. And that's a debatable, evolving topic, which has been, discussed quite a bit in US. My take on that is that, both techniques do have pros and cons, right? But I believe, Kashif answered that question already, and I agree with Kashif that there has to be a hybrid process where these 2 techniques can kind of supplement each other. And currently in my practice, when I do procedures to an area which is highly vascular, like when I'm doing a hip joint RFA, I try to localize the femoral artery by using the ultrasound, mark that artery on the skin, and then I, take a shot with my fluoro to make sure that my needle path or track is away from the femoral artery. As I discussed briefly, with stellate ganglion block, a lot of people are shifting towards ultrasound. The only problem which I do have with ultrasound only is that if my needle is in a small vessel, I can do additional subsection angiography on fluoro, and that'll give me an idea if I'm in the vessel or not. Ultrasound might miss that. So, there's a lot of talk about ultrasound. I think fluoro will have its own place in the future as well. Yeah, that's my take on it.
Okay. Kashif, do you want to add a few more words on it, please?
No, I agree with Ubaid. So basically, as Ubaid mentioned, you can see vascular structures better with ultrasound, but you cannot align needles as well as you do with under fluoroscope, and you can't, do DSA, and you can't visualize the contrast spread, etc. So both techniques have their own pros and cons, and if we can combine both of them, then that would be even better. Yeah, I agree with Ubaid.
Okay, so the next question comes from our junior resident, and this is for Dr. Phillip. He says, is neuromodulation a permanent solution for pain? Asad, no, it's not. Is there a chance that the pain can occur again after a successful procedure? So Dr. Hu, would you like to answer our junior anesthetist here, please?
Thank you for the question. It's an interesting one, and it shows that we're motivated by positive outcomes for our patients. The reason that pain is such a challenging condition, chronic pain is such a challenging condition to treat, is that there are so many variable factors. So if you take down just specifically looking at the biology and the technical aspects of it, neuromodulation, when employed, can be very successful. A successful outcome is defined as a 50% reduction in pain associated with good functional improvements. However, there are so many different issues involved. So if we take spinal cord stimulation, for example, a stimulator trial can work very well and an implant can work very well, but over the years, things can happen. There is a concept of habituation. You sit on your chair, and after a while, you don't realize that you're sitting on a chair because your nerves decide that this input is no longer salient. Therefore, it is cut off in terms of its significance. So in the same way, your nerves can also get habituated from the stimulation process. That's why currently we have 4 or 5 different stimulation algorithms that can try to prevent that. There are also technical reasons in terms of the lead placements, migration, scarring, and also the impedance changes that can also cause difficulties in getting appropriate stimulation. So technology has stepped up to the game. There are so many different advancements. For example, closed loop stimulation, where the stimulator can actually sense whether you're standing, sitting, because the distance between the epidural space and your spinal cord changes. And for that perspective, the wire can also act as a receiver as well as a transmitter. So you not only send what you want to send to the patient, and you can tell that the patient receives what you send. So that's the short answer. In terms of intrathecal drug delivery, again, technical issues can happen. You can deliver the drug to the specific location. Granulomas can form. Circulation can be impaired. Receptors can change. So therefore, the short answer is no, it's not a permanent solution. The pain can recur from either a worsening of the condition, as can happen in cancer situations through disease progression, or it can be a ceiling of therapy.
Thank you very much, Dr. Phillip. The next question comes from an anonymous attendee, which is what's the future line of action or advancement for pain management in cancer patients? This is open to all the panelists, please. Anyone can answer. Dr. Atikur Rahman, are you there?
Yeah, I'm there. So, Rumana, you are just putting me in a very difficult situation. Dr. Phillip Hugh is sitting there and you are asking me. So I'll just leave it to Dr. Hugh there. Please, Dr. Hugh, go ahead. He has mentioned an article. I have gone through that article, but Dr. Hugh, please.
Okay. The future line of action of advancement for pain management in cancer patients, I think that some of the principles continue to apply and are very important. Diagnosis is important. We've gone through quite a lot in terms of why patients will have the pain during treatment, because of the tumor, or after treatment. If you find the diagnosis, if you find the type of pain, for example, neuropathic pain responds to different medications, and if we do what we do well and what we know better, then that will be a really good starting point for the future line of action of pain management in cancer patients. You've had a discussion about how expertise is limited, but there's so much potential, there's so much talent that could be tapped. One of the simplest things would be a structured national strategy with execution in terms of a faculty. So you can start with training, which you are doing already, and then you can start with education and also with awareness. So pain management is not just the sole remit of a certain number of doctors. All doctors should be able to know how to treat pain to a certain level. You should also know your limitations of your own skill set, and you should also have the intellectual curiosity and knowledge to know what other alternative treatments are there, and to be an endless, passionate advocate for your patients. And that way, we've also heard about ethical concerns. If you practice your medicine with knowledge, with competence, and ethical considerations, I think that would be a good start.
Okay, thank you very much, Dr. Hu. Next question comes from Dr. Almas Iqbal. How effective is 8% capsaicin patch for diabetic neuropathy and chemotherapy-induced neuropathy? Open to the panelists, please.
So I'll just start with my comment. So thank you, Dr. Almas. So basically, capsaicin patch works for any neuropathic condition where you have an area of allodynia. So basically, with each subsequent application, you see the shrinkage of the area of allodynia. Problem with diabetic neuropathy and this cancer chemotherapy-induced neuropathic pain is that the area is very wide. It's a very huge area. So generally, they have glove and stocking distribution. So the problem is you cannot sort of cover the area with capsaicin patches. That's why it's very challenging to treat diabetic neuropathic pain and chemotherapy-induced neuropathic pain. So capsaicin patch we rarely use for these two conditions. So most of the
Thank you.
time, we use capsules and patch for conditions where you have a limited area of allodynia, like in post-herpetic neuralgia, or allodynia in an area, in a specific dermatome, which you can cover with the patch.
Thank you very much, Kashif. We have another question from an anonymous attendee, but I suppose it's a bit controversial question, so I'll just read it on and then we'll move on to the next one. The question is, well, pain consultants are also not well trained. Some have done diplomas and even MSc or short courses and call themselves pain specialist. What to do about them? So I would just pass on this. I think we'll move on to the next question. The next question is by Almas again, and she says, what about the pain physiotherapist, etc., training along with the pain physician as teamwork?
I think this question relates to very much like building a multidisciplinary team. And now we have very good tools, like IASP has brought out this manual specifically for developing countries. And in that, they lay out the job description of a physiotherapist, whoever wants to work in a pain team. What skills they should have, what training should they have, and what administrative skills should they have. So they have laid out the whole essential criteria for the job description for you, bringing up in the plate. So any people at institutional level heads, any physiotherapist who is interested in working with the pain team or developing a pain team can fulfill that training criteria. That training criteria credibility has to be decided nationally at countries level, that what is our minimal. And that is now another thing, if that physiotherapist herself becomes a pain physician and starts doing their own, that's the dilemma in Pakistan we face. But it's all about moving in the right direction and taking the first steps. So we have a lot of material available to us now to start the journey.
Okay, thank you.
I would just like to comment on, this physiotherapy related, in the pain management. So my take on that is that for the young trainees who are listening to this wonderful symposium, that whatever the condition we are trying to treat by physical therapy, whether it's a radiculopathy, whether it's a CRPS, SI joint pain, what I've seen over and over again, in US, we have limited sessions per year allowed by the insurance. So we want to utilize them, very wisely. I try to treat the pain generator multidisciplinary by pharmacotherapy and interventions. And once the pain is somewhat relieved, that's the time when I send the patient to physical therapist so that they can get the maximum out of it. So, that's the way I think we should look at things, that we utilize the resources in the best possible and effective way. Thank you.
Thank you. So the next question is, how can we establish proper referral system from DHQs to the tertiary care centers? Thanks. I think this is coming from Gujarat probably. And I'll ask Dr. Gohar Afshan to please answer this. Is Dr. Gohar Afshan online with us?
Sorry,
Can you hear me, Doc?
Yes,
Dr. Gohar, can you hear me?
I can hear you. So you are asking about, sorry for my voice, I'm suffering from very bad flu. So you are asking about the reference system. Actually, the first thing which we all expect from our national bodies, especially the licensing body like PMC, they should establish that this is a discipline. Currently, in PMC, or our licensing body, the Pakistan Medical and Dental Council earlier and now PMC, it is not established discipline. Until it is established discipline, we cannot make a reference system from primary to secondary to tertiary care. Normally the pain, which is we all know that this is one of the commonest symptoms, and in most of the countries, it is actually referred from the primary physicians. They pick up which patient should go to the pain physician. Usually the pain setup is in the tertiary care center everywhere in the world, is not in the Pakistan, everywhere. This is the tertiary care discipline. And we actually need to realize our licensing bodies that who can practice, where can be referred the patient. It is not like anyone who himself claim that I'm a pain physician and start just make a board, and this is a pain clinic, this is a pain center, and the people start jumping that. This is very unfortunate that we don't have a system right now. But I think the only way which I can see is the PMC, which recognize this as a discipline, a recognized discipline, and then we make a referral system. I'm sorry.
Thank you very much, Dr. Gohar. I think we should conclude the session now because we are short of time and our next session starts in the next 4 or 5 minutes. Dr. Faraz Mansoor has asked a question which I'll answer him personally later on. And from my side, we end this session. This is my last piece of work for Shaukat Khanum Memorial Cancer Hospital. Goodbye to Shaukat Khanum and goodbye everyone. Thank you very much for your attendance.
Thank you.
Thank you very much.
Bismillah ar-Rahman ar-Rahim. Welcome to the second session of Anesthesia and Pain Medicine at 20th Symposium of the Shaukat Khanum Memorial Cancer Hospital. I welcome everybody. We have 6 talks today, both from very eminent international and national faculty. And may I request everyone to kindly put their questions in the end so that we have ample time to answer them along with our panelists and to our presenters. So our first presenter today is Dr. Umar Farooq, who is going to talk about in situ simulation, why we fail to deliver. Dr. Umar Farooq Khaja is one of the consultant anesthetists at the Shaukat Khanum Memorial Cancer Hospital at Lahore. He is a fellow from both the Royal College of Anaesthetists of England and from Ireland. And as a part of his training from UK, he did his fellowship in simulation, and he has got special interest in simulation. So over to Dr. Umar Farooq, please.
Good afternoon, everyone. My name is Dr. Umar Farooq. I am a consultant anesthetist in Shaukat Khanum Memorial Hospital, Lahore. The topic for discussion today is in situ simulation and why we fail to deliver. First of all, I would like to thank Dr. Asma for the introduction and Shaukat Khanum Symposium team for inviting me to deliver this talk. The learning objectives will be to define what is in situ simulation, what is the evidence behind to support in situ simulation, key consideration, examples from my own experience, and then the references. In situ simulation is defined as simulated encounters in the exact settings where they are expected to occur, as opposed to dedicated simulation labs or center. So if you're expecting an encounter to take place in an outpatient setting, then the simulation would take place in an outpatient setting, not in a lab or in a classroom. There is a lot of evidence now emerging to support the use of in situ simulation in various aspects of patient care, like better patient outcomes, improving patient safety, identifying and resolving latent errors. Latent errors are the errors that are hidden in the system that can lead to a potential harm. Test running of newly established facilities, multidisciplinary and interactive training, highlighting human factor issues. Human factors are sort of non-clinical issues that contribute a lot towards patient care. Improving quality of patient care, which I think is the objective for all of our teaching and training, and improving familiarity with the environment. Now, this is a very vital slide for my presentation, because in situ simulation involves a lot of key steps, but we tend to do very few of them, and that is the reason why we fail to deliver. And for me, when I was doing a simulation fellowship, this was the key point, because before doing the fellowship, I was one of those people who was not following all the steps in order to achieve the goal. So I was asked, if you have a mannequin, if you have a bit of a time, can you come and deliver the training? But that is not the way to do in situ simulation. So let's enlist the key factors and key steps, and then we will go in a bit of detail of why and how these are important in achieving successful in situ simulation training. So team meeting, needs analysis, timelines, backup plan, faculty assignment, resources, parent-team collaboration, setup, pre-brief, scenario, debrief and latent errors, faculty debrief, and feedback to the parent department. Now, the ones in red are sort of the things which we tend to do, like needs analysis, what is the reason, maybe a bit of focus on the scenario, and then a bit of debrief. But the rest, I have seen in a lot of simulation settings, they are not done. And that's what leads to the failure itself. Now, team meeting is very important. I think all the multidisciplinary team members should be there. The stakeholders have to be there. If we are doing simulation training for physician, nurses, paramedics, because it's a teamwork, the representatives have to be there, and they should highlight their own learning objectives from their point of view and from the point of view of the team itself. And that will lead to a successful delivery of the training session. Needs analysis is the key to set up any simulation. The reason for training exercise, was there any serious untoward incident that has led to this, or it's part of the curriculum? And then learning objectives have to be smart, they have to be well defined, and the whole of the exercise should work towards achieving them. And I think if we have poorly defined learning objectives, then the poor delivery of training will occur, unfortunately. And that is, I think, very, very important. Of time so well spent on this is very well invested for a better training outcome. Now, the timelines have to be very much defined. And the reason for that is you are using an actual clinical environment. So it's a very precious time of training. So you have to book the location, like if it's a spare theater, a week before or well in advance, and then a reminder should be set, because there might be an unplanned activity or an emergency procedure that needs to be accommodated in that setting, and then you have to go for your plan B. These are the rough guidelines, like it takes about 30 minutes, it might take about 30 minutes for the setup, 20 minutes for the scenario, 40 minutes for the debrief, and then tidying up. So everything has to be accounted for. And if you don't take small bits into consideration, then it might lead to a problem. And we have to be very, very careful about this, that we are using an actual clinical environment, and it should not by any chance or means harm the patient's safety. The backup plan is very, very important for my consideration. Like if an emergencies arrive, where to relocate, what will the team members do, what are the tasks allocated to them. I was involved in a situation where we had a pediatric emergency coming to the pediatric resus bay, and we were delivering teaching over there. And the estimated time of arrival was 2 minutes. And the scenario was in full swing with nurses and doctors involved. But what we did manage to do was evacuate the place within no time. And there was no patient compromise. And we were able to go to a place which we had already highlighted to deliver the rest of the training in a form of hybrid simulation, where we evaluated the scenario which we had done, so had a debrief for that. And then the patient or relative discussion was part of the scenario which we were able to deliver in the classroom, because you don't have to be in the exact setting for that. So it is important to have a backup plan as we are using an actual clinical environment. Faculty assignment, so every member should have a very well-defined role, like who's going to be the actor, what is their script going to be, the debriefer, facilitator, technical support staff, stooge. Stooge is a person from the assigned from the parent team, and that is presented as part of the team undertaking the training, like it could be a student nurse who will be there and their part. So if there's certain things you have to direct the team in certain way, then the stooge would come into play, and they will ask a certain sort of question to guide the team in the right direction. And that will not get the team out from the real scenario itself or the reality which you have created. The simulation fidelity is very important. A lot of work is now being done on whether the high fidelity or low fidelity or the actors are the key points for the simulation. And I think it's horses for the courses. So if you have a conversation scenario, where you have a discussion scenario, then probably the actor will be the most high fidelity you are going to get, rather than a mannequin which somebody else is speaking through. And if you have a resuscitation scenario where you have to do a lot of lines or tubes and stuff, then a high fidelity mannequin, which gives you the real-time response, is the way to go. Now, resources, it's important to highlight where you are going to use the resources from, whether it's going to be from the local or from the lab, the mannequin itself, and which rooms you are going to use. So in labor ward, we did a lot of scenarios in England, and there was a room which was not used much, but had a very similar setup to the other rooms. So we were using that. And that would create the reality itself, but it would help us be there for a longer period of time without compromising patient care. Now, collaboration with the parent team, you have to go and discuss with the site manager, what are your aims and objectives, why you're doing something, the training, what is the purpose of it, and then do a pre-arranged visit if you're not working there, so to know where the facilities are and what are the important considerations to be taken into consideration for the training exercise. Now, setting up the mannequin, sometimes they're high fidelity, they are a bit complicated, might take a long time to set up, and then the equipment itself, the location of the equipment. So if it is placed in the lab, you have to take it to the actual workplace. It might take time. I think pre-brief is one area which needs to be carefully taken into consideration, because here you have, this is a sort of final check before you deliver the actual scenario and the training. So you have to inform the team whether you are going to use a live emergency buzzer so they don't panic and they are aware of what's going on. Then the final checks with the mannequin, with your equipment, where the camera is placed, where the wiring is, so it's a safe environment to deliver the training. Then introduction to the SimMan. I think if you have to get the maximum out of the high fidelity SimMan, then people need to know what it can and what it cannot do. So the do's and don'ts are very important. That if the SimMan is breathing and you want them to hear added sounds, ronchi or wheeze, then you have to tell them that this is what you will be able to listen. Or, you don't point out exactly to what you want them to listen, but you have to tell them that these are the features which are there to be look out for. Otherwise, a lot of time I have seen participants assuming, oh, we thought, like with the other exercise, that you will tell us that you are hearing wheeze, rather than actually, because we have never heard of wheeze on a mannequin before. So that takes away from the reality. So it's very important that the introduction to the SimMan and what it can and cannot do is highlighted to the participants. Now, the scenario itself is should be well rehearsed so that you know the limitations or the strong and the weak points yourself as a team. Then the escape route has to be defined. Like if the team is not going in the right place where you want the learning objectives to be delivered, then you might have a backup plan, like whether the consultant will go in, a member of the team will go in as a consultant, or the stooge is prompted through the mic system, which is just known to the stooge, him or herself, that they are going to prompt the team in the right direction. Because remember, it is a learning exercise, it is a training which you are trying to deliver. So you can guide the team in a direction where you want to have the learning objectives delivered to them. Debriefing and later awareness, that is the key consideration for any simulation scenario. So this is where the learning happens. And roughly it has been said that the debrief to simulation scenario needs to be like, the time ratio needs to be 2:1 or 3:1. Because here the discussion is going to happen about what the participants have done, and more importantly, how you are going to highlight the learning objectives and their delivery. So what I used was advocacy with inquiry model, and there is a whole workshop on that. So it's very limited time. We will not go into the details for that, but I found it very useful because I think the important bit is to highlight the process, not just the mistake. So you did not put on the oxygen is not the most important thing for me. The most important thing for me is that why a person did not do oxygen, what we can do to prevent that happening in the next time. So for that, I have found advocacy with inquiry model a very useful tool to use. Risk matrix, we used to use National Patient Safety Agency risk matrix, and there are a few more around as well. So you can use any, so to define what could have been the harm and what is the grade of it and the possibility of getting it repeated. So that needs to be highlighted as well. Then you have a faculty brief, you wind up, you come back, you put everything in place, and then sit down, have a cup of coffee, and then go through the exercise itself bit by bit and do a constructive analysis and make improvement for the future, because we used to learn a lot. A lot of input was coming from the tech team and the facilitator and debriefer, where the problem was and what could be done to improve it in the future. The feedback to the parent team is pivotal, as if you have found latent errors, the hidden errors in the system, you can risk stratify them and then discuss with the parent team. And again, the protocols and guidelines can be made out of that. I think because the simulation exercise is happening in the real actual environment, it is much more easier to make a change. Like we did a scenario on perimortem cesarean section, and there were no perimortem cesarean section packs. So we could just highlight it by delivering that scenario there. And within 2 weeks, all the resuscitation trolley in one of the hospitals in UK had this perimortem section pack. So it's important to deliver, discuss with the parent team and have the necessary change made. And that's where the quality improvement comes into play. And for me, in situ simulation is one of the most powerful tools where you can improve the quality very quickly. There are rewards, like I think one of the best feedbacks I had was one of the junior anesthesia technician We did a scenario for them, which was highlighting the location. One of the learning objective was to highlight the location of the resuscitation difficulty airway trolley and resuscitation trolley. So this junior anesthesia technician comes running to me and tells me that, after the simulation we delivered 2 or 3 days later, they had a difficulty airway scenario in actual life. And she was able to go there, volunteer, and bring the difficulty airway trolley in no time. And she felt very valued by the team and had a good confidence building herself. So she was very, very happy and she thanked me a lot. And that, I think, is the essence that once you deliver the scenario and you sort of achieve the learning objective, it can have a big impact on the participants themselves. We did introduce this perimortem cesarean section back in no time because we were able to prove that it's not there. And then sometimes, very rarely, you get the standing ovation. So in one of the hospital, we delivered 3 scenarios to theater team, and then they all stood up. There were about 10 members and gave us the standing ovation, so which again felt very good. So in conclusion, I think it's one of the best tools we have to be used, but it has to be properly planned and executed. So these are the references which I have got, and then we will take the questions at the end. And thank you very much.
All right. Thank you very much, Dr. Umar Farooq, for a very interesting and very inspiring talk. And it has been my personal dream since I came back to Pakistan to establish a clinical skills lab where we can have the practice of simulation. Anyhow, our next speaker is a very eminent speaker, again from America, Professor Vijay Gotumukala, who is a professor at the University of Texas at MD Anderson Cancer Center. And he's going to talk about the role of anesthesia in prevention of cancer recurrence. Professor Gotumukala is a fellow of the Royal College of Anaesthetists at England, and then he moved to United States, where he did his board certification and started his anesthesiology practice. And he's a professor at the MD Anderson now. He has got special interest in enhanced recovery after surgery in the ERAS and the role of anesthesia in cancer recurrence. So here we are with Professor Gotumukala.
Good afternoon. My name is Vijay Gotumukala. I'm a professor of anesthesiology and perioperative medicine at the University of Texas, MD Anderson Cancer Center in Houston, Texas. I want to thank the organizers of Shaukat Khanum Cancer Center for giving me this opportunity to be with you at your meeting and present to you on a topic that is near and dear to my heart. The topic I'm going to be discussing this afternoon with you is anesthetic techniques and cancer recurrence. What is the evidence? But before we go forward, I want to dedicate this talk to our patients with cancer who show so much courage, strength, and hope in their fight against cancer, and who give me and all of you an inspiration to fight on their behalf every day. I also want to acknowledge our collaborative group across the world who's been working diligently over the last 10 years in coming together and sharing our research, our clinical protocols and programs in this common goal to help our patients with cancer. Since this is a scientific program, I have to mention to you that I have no financial conflicts of interest which will pose any bearing to this talk today. So over the next 25 minutes or so, I'm going to briefly discuss the topic in these sections. 1, discuss cancer epidemiology and perioperative implications. 2, discuss biology of the perioperative neuroinflammatory immune responses and the implications for oncologic surgery. Number 3, discuss current science and evidence of anesthetic techniques to influence oncological outcomes. And finally, discuss the role of us as perioperative clinicians and anesthetic practitioners on how today, with the best clinical evidence we have to date, can help our patients have better oncologic outcomes. So it is estimated that by 2030, across the world, there's going to be a 50% increase in the incidence of cancer and a 60% increase in mortality during the same time frame. But it is heartening to note that since the early 90s, at least in the Western world, there has been a steady decline in the cancer deaths per 100,000 population. However, given the increasing exponential increase in population, but also more importantly, the elderly, the over age of 60, there has been an overall increase in the overall total number of deaths due to cancer. So while there has been an increase in the death rate, the total number of deaths due to cancer has been increasing. And it's estimated that by 2030, we will be needing about 45 million cancer operations across the world. And as most of us know, predominantly cancer care is delivered in the community, not in the comprehensive cancer care centers like Shaukat Khanum Cancer Center. So no matter where in the world you practice and what kind of a practice setup you're in, whether you're in a small community hospital, a district regional hospital, a tertiary academic center, or in a comprehensive cancer care centers, about 70% of your patient population is going to be either a patient with cancer undergoing active therapies or a cancer survivor who may be coming for other cancer care related conditions or even non-oncological conditions. So it's really important for us to understand the impact of our anesthetic techniques and strategies on cancer outcomes. So it's not unreasonable for us to ask the question, can anesthetic techniques and perioperative strategies influence cancer outcomes? Now, the hypothesis behind this is that if we modulate the perioperative inflammatory immune responses with a regional block, thereby attenuating surgical stress response and possibly minimizing the use of opioids, we could benefit our patients by prolonging recurrence-free survival. So traditionally, when we were taught about the perioperative stress response, our main focus had been on the perioperative neuroendocrine and metabolic responses. However, it's only in the last about 15 to 20 years, there has been an increasing focus on evaluating the role of inflammation and immune responses as part of this neuroinflammatory signaling and how this may particularly be responsible for some intermediate and long-term outcomes, including cancer outcomes. So inflammation and immune responses have become a significant part of this. And over the same time frame of 15 to 20 years, we have a better understanding of the role of this neuroinflammatory signaling, and particularly in cancer patients, how this may influence factors that can increase the risk for locoregional distant metastases, either through increasing angiogenesis or by the immune modulation effects. Now, if you're looking purely from the lens of the immune system, Broadly, the immune responses can be divided into two types: a T1 response, where they help in the elimination of cancer cells, and this predominantly facilitated by T helper 1 cells, natural killer cells, and cytotoxic lymphocytes. On the other hand, we could also see a T2 response, which is predominantly mediated by the inflammatory responses like COX and prostaglandins, and mediated by T2 cells, T regulatory cells, and T helper 17 cells. Now, if the immune response results in a T2 response, it could lead to either dormancy or immune escape by the cancer cells, thereby leading to, again, local, regional, or distant metastases. So when we talk about the effects of anesthetic techniques or perioperative strategies on influencing oncologic outcomes, we have to look at these factors. So which are the factors which are influencing the T1 response, and which are the factors which influence the T2 response, and how we can enhance the T1 response and minimize the T2 response. So here you can see that the factors which enhance the T1 response include propofol, COX-2 inhibitors, or other non-steroidal anti-inflammatory drugs, regional blocks, amide local anesthetics, beta blockers, and immunonutrition, particularly arginine and omega-3 fatty acids. On the other hand, the T2 response is influenced by inflammation, activation of the hypothalamus axis and sympathetic nervous system, and everything else that we would like to avoid during the perioperative period, which includes hypotension, hypothermia, hyperglycemia, and blood transfusion. Now, volatile anesthetics and morphine are also believed to enhance the T2 response. So in the fight against cancer, you want to do everything we can to enhance the T1 and diminish the T2 response. So now let's look at each of these factors in a little bit more detail about what's the science behind it and what's the evidence we have to do. So let's start off with regional anesthesia and analgesia. Now, the whole interest on this topic was began by Exadactylus and Buggy from Ireland when they published in Anesthesiology in 2006 on their experience with mastectomies being done under a paravertebral block. And the title of this publication was, "Can anesthetic technique for primary breast cancer surgery affect recurrence or metastases?" So in their small study of about 40 patients in each group, what they found was women who had mastectomy with a paravertebral block had about a 17% absolute increase in recurrence-free survival when followed up to 3 years. So this really gave the impetus for most of us working in comprehensive cancer care centers and other major tertiary academic centers to see if indeed regional anesthesia or analgesia is going to make a difference. So since that publication in 2006, over the last 15 years, there have been about 50 publications looking at this question in various surgical procedures. Now, over the next 6 slides, I'm going to briefly run the various studies that have been published on this topic. Now, most of these are retrospective studies or meta-analysis and systemic reviews, and half of which have shown a benefit for regional block in prolonging recurrence-free survival, and the other half have shown no difference in the effects of regional blocks on cancer-specific survivals. However, until about 2019, there were only 3 randomized controlled trials which were done looking at the effects of GA plus epidural compared to a GA alone on overall survival and other clinical outcomes. But there was a post-hoc analysis which was performed on each of these randomized controlled trials. Now, one was Christopherson et al. And colleagues, just published in 2008, where they looked predominantly at patients who have undergone colectomy. And they found that the GA plus epidural group showed improved overall survival compared to the GA alone group in patients undergoing colectomy, but more importantly, who have not had metastases at the time of surgery when followed up to about 1.5 years. Contrary to this, Ban Sui and colleagues have published their post-hoc analysis in 2010, looking at patients who are undergoing radical prostatectomy with GA plus epidural versus GA alone, and they found no difference in disease-specific survival. Paul Miles and colleagues from Australia, they published their master trial in 2011, where they were looking at patients undergoing abdominal cancer surgery. And a post-hoc analysis of this trial have also not shown any difference in overall or recurrence-free survival with an epidural. So just like in the retrospective studies and meta-analysis and systemic reviews, where the benefit of a regional block was only shown in half of those studies, even in these post-hoc analysis of 3 randomized controlled trials, which were done with a different primary outcome, when looked at cancer-specific survivals, again, the jury was still up. So in 2019, Dan Sessler and group have published the first randomized controlled trial looking at the effects of regional blocks on cancer-specific survivals as the primary outcome in Lancet. This is a well-done study overall, performed in 17 centers in Europe, North America, South America, and Asia, with about 1,000 patients in the paravertebral group and 1,000 patients in the general group. And after definite clinically relevant substratification on various factors which influence oncologic outcomes, this study was not able to show any benefit of a paravertebral block in women undergoing mastectomy for breast cancer compared to pure general anesthesia alone. Now, there was another post-hoc analysis of a combined GA epidural versus GA alone done in Peking University of major abdominal and open cavity surgical procedures. In this large randomized controlled trial, about 850 patients were included in the combined epidural general anesthesia group and about 860 in the general anesthesia group alone. As you can see in the survival curves on your right, there has not been any difference on a post-hoc analysis when they looked at cancer-specific survivals between the two groups, and so was the case for overall survival as well. Again, another post-hoc analysis of a recently conducted large randomized controlled trial looking at the effects of general anesthesia versus general plus epidural and looking at cancer-specific outcomes. And this was published again in Anesthesiology earlier this year. Now, the question has always been that in the Sessler's group in breast cancer surgery, maybe the effect size or the influence of the regional block is not that much because mastectomy is a minor surgery. So again, colleagues from Peking University in Beijing have done an epidural with general anesthesia compared to general anesthesia alone in patients having thoracotomies for lung cancer. And this was a randomized controlled trial looking at recurrence-free survival as the primary outcome. Again, there were 200 patients, and each of the groups, very well done randomized controlled trial. And just like the previous trials, there was no difference in recurrence-free survival between the two groups. However, when they looked at their secondary endpoints, they saw a definite advantage for the epidural with regards to ICU admissions, with regards to the duration of chest tube that is needed in the post-operative period, and length of hospital stay. So where do we stand right now in the later part of 2021 with regards to the effects of regional anesthesia and cancer outcomes? To date, there is no level 1 evidence which shows that regional analgesia has a definite effect on prolonging recurrence-free and other cancer-specific survival outcomes. That does not mean we should not be using regional analgesia. I'm a strong believer of regional analgesia, and I think regional analgesia should be used for every patient when appropriate and indicated to minimize opioid-related adverse events as part of our enhanced recovery programs, as we know that regional analgesia does decrease pulmonary complications, particularly in the morbidly obese patient, and can also enhance overall patient satisfaction and experience. So don't give away regional analgesia yet. Continue to use it where appropriate and indicated to still have positive benefits on patient experience, satisfaction, and as part of our multimodal opioid sparing strategies and enhanced recovery programs. So the question then is, where else is there a potential to influence oncologic outcomes, particularly for us as anesthesiologists? And it so happens that cancer cells exhibit mu-opioid receptors, voltage-gated sodium channels, GABAergic receptors, and are also influenced by COX-2 and beta-adrenergic signaling. So when we go back again to this figure where we are looking at the T1 responses and T2 responses, as you can see that propofol, COX-2 inhibitors, amide local anesthetics, and the use of beta antagonists during the perioperative period can elicit a T1 response and in theory be beneficial to patient outcomes, while volatile anesthetics and morphine with a predominantly T2 response may not be that beneficial. Now, what is the evidence? In the limited time we have, I will not be able to discuss all of these factors, but we'll just touch on opioids and anesthetic agents. Now, the story between use of opioids and cancer biology, at least in the animal studies, it's not new. It has been going on at least for a better part of 3 decades, maybe even close to 4 decades.
Well, Dr. Vijay Kotamukala, you are absolutely right. There is not enough time really to go through that very lengthy discussion. We are really running short of time. So let's go to our next speaker, who is Professor Dr. Saida Haider. Thank you very much, Dr. Saida Haider, for joining us today. Professor Dr. Saida Haider is one of the consultants at Indus Hospital, Karachi, and she is one of the torchbearers of the specialty of anesthesia in Pakistan. She had been a previous dean of the Faculty of Anesthesia of College of Physicians and Surgeons, and she is the patron of the Pakistan Society of Anesthesiologists, Karachi. She is going to talk about mentors' role in trainees' well-being. Over to Dr. Professor Saida Haider, please.
Hello, everyone, and a very good morning to all my virtual audience, and a very big thank you to the organizers for having invited me to this prestigious conference and to have this talk on a very important topic of mentorship. A subject that is very close to my heart, maybe because I have been involved with teaching and training for the last 30 years. This is the place where I work, in this hospital. It started about 14 years ago, and you can see those huge buildings coming up. Our motto is quality care free of cost. And it is not only that expansion is taking place at the main head office or at the main branch of Indus. We are spread all over the country now in more than one province. No, I have no personal or professional conflict of interest. As medical doctors, we belong to the noblest of all professions, and there's no doubt about that. But we are especially placed in a unique opportunity because on top of being doctors, we are teachers and trainers. Now, this is an often quoted Quranic saying, saving one life is like saving humanity. But do we realize that as teachers and trainers, we can have an impact on so many minds, an opportunity to train so many minds of the future doctors who are going to treat you and me tomorrow? The learning outcome of teaching and training basically is supposed to be like we impart some knowledge, we pass on some skills, and we try and inculcate an attitude in our trainees of good bedside manners, being good to the patient, their families, and their peers. Now I'm talking about anesthesiologists only, but do we realize that the contribution to the community is actually massive? It is only because of these trained and qualified anesthesiologists today that average patient care in OR has become quality patient care. So many advanced surgical procedures can be done today because we have qualified and trained anesthesiologists, and we have moved on from simple surgical intervention. When they come as fresh graduates to us with impressionable raw minds, that's the best place where we can help them develop into wholesome human beings and qualified anesthesiologists. Now, these individuals, actually, they contribute to the community, and the community contributes to the nation. So we actually participate in the development of our nation, actually beyond borders. I have so many of my students who today not only work in the Middle East, but UK and Ireland, and I hope that they're doing a good job there. What is the concept of mentoring? Is it the same as supervising? Well, this gentleman that you see in this picture is certainly a supervisor and certainly a teacher. Is his body language that of a mentor? Well, I'm not too sure about that. The problem is not really with us. It is because when the CPSP appoints us as a supervisor, all they require is that we have a diploma or a degree, a certain diploma or a degree. We should have some work experience and we should have done some workshops, mandatory workshops of the CPSP for supervisors. And then we are expected to cover up the 4-year training program of these trainees, finish their curriculum in that period, impart some knowledge and skills to them, help them with their dissertations or writing 2 papers, approve their ELOCs, periodic internal evaluations, and then we end up as examiners. But how many of us are really mentors? How many of us water those plants, those growing trees up there? Well, let me share some personal experience of mine. I worked at the Dow University of Health Sciences from 1989 to 2012. And during that period, 300 CPS and MCPS were trained and qualified from there. Of course, there were many supervisors, but the ones that registered under me also must be about 75 to 80. And we try to make them into wholesome human beings, and I hope they are so. And since then, since 2012, I joined in this hospital, and I'm here till today. We are 5 supervisors and 15 specialists. And during this short period, we have trained about 50 anesthesiologists. 14 of them have qualified as FCPS. 23 have done their intermediate module, 10 as MCPS. And with a heavy heart, I say that 2 of them could not do any exam. A mentor is actually beyond the supervisors. Trainees need mentors, not just supervisors, because each trainee is an individual. Now I have more than one example fitting into each one of those circles. Some of them have personality issues, some have psychiatric issues. I have an example, I tell you, of each one of them. Some have psychological issues, some have massive financial issues, tragedies in personal life. Some of them are political leaders, and you have to deal with them. And, you have to mentor them into a trained and a qualified anesthesiologist. Some you have to deal with who are failures in life, but you have to help them out.
And on top of it, they're joining this training program, which is very challenging and demanding. The speciality of anesthesia and critical care, no doubt, gives immediate reward and great satisfaction when the patient gets up at the end of the surgery, pain-free, or a critical care patient leaves the ICU. However, remember that when they're coming into this training program, they're coming up with into this new routine with long hours and extraordinary demands with associated stresses.
Anesthesiology is basically a team sport. There are too many teams working in an OR, a demanding surgeon, the OR technician, the anesthesia technician, the trainees. The field is large and there are too many players, and you have to learn to deal with them. Isn't it our daily routine that we are anesthetizing or having a colleague in some ICU with some critical care problem, or a family member of yourself or your colleague, a high-risk young patient, your heart beats with them, a complicated obstetric case, a difficult intubation, some days you have to break bad news. And on top of it, these trainees have academic deadlines. Now, COVID-19, who doesn't know the stress and the strain and the pressure that this disease has brought into our lives, with that looming over our own head as well as our family and friends. It has changed the world. Stress, can it be rewarding? Yes, you can turn it into a rewarding, it can be rewarding, yes. Enjoyment that comes from relieving pain and ultrasound-guided nerve block, relieving pain and doing surgery in that, walking them along with successful surgery. Create an environment that is informal and confidential. Make them to be one of your team members. Coffee breaks, little things like coffee breaks, inculcating confidence in them. You are a mentor and you are expected to recognize their stresses and convert them into productivity and motivation. You can actually help them reframe their day. Mentoring, the main issue, the main function of which is training, can do more than that. It can be supportive. You can be supportive. You can direct them, channelize them towards research or critical care or pain management or anesthesiology or whatever they are good at. Help them, motivate them, achieve their goals, make their success your success. By the way, remember that you're not a puzzle solver if you are a mentor. You are actually helping your trainee develop a healthy mind, productive soul, lace them with skills to maximize performance. Turn their dilemmas into opportunities. Help them with their career decisions, work plan, academics. Not so many of them are having altercations with their peers, with their seniors, with their juniors. You can sort of sort that out. demanding senior colleagues. So many faces come vivid to my mind when I say that, demanding senior colleagues. The OR environment, now how important that is. I narrate a story that of 25 years ago, my own self. We had a very lengthy, difficult day ahead of us with splenorenal shunt, and I don't know what all was there on the list. And we were dreading that day, and when the surgeon walks in, he walks in with a box of sandwiches, homemade sandwiches and chocolate, and say, "Oh, we're going to have breaks. We're going to do this in the break and that in the break," and that really changed the atmosphere. And I still remember that day as a pleasant day, although 25 years have passed. So what skills does a mentor require? He or she needs to listen, not just hear, have empathy, not sympathy, help them become better at helping themselves. Remember, just like the pocket budget, everybody has a body budget. There's no one recipe for all. Help them write their own prescription. You just have to help them. They will say what is required. Maybe someone just requires some exercise or meditation or sleep. A box of tissues, opening the floodgate, it helps a lot sometimes. Now, the Association of Anaesthetists actually does formal courses on mentorship, things like coffee and gas well-being podcasts. As early as 1970, Gerard Egan wrote this book on skilled helper model. Actually, mentors are skilled helpers. It's a beautiful book to go through. Now, I came across this study, the Hayes group of study, where they were differentiating between an average and a best organization. And what we realized was that mentorship was the single most important contributor. 35% of the time, the best organization had a lot of mentors to help their trainees. Now, this is what your purpose is. This is what you can do. Unentangle their brain networks and put it in the right place. That's what a mentor's role is in trainees' well-being. You can help them with the 3 C's. Control what you can, and you have to teach them that the only thing that they can control is themselves. You don't have control over anyone else or anything else. And learn to cope with what you can't. I was hearing this interview of the CEO of Pepsi, the lady, and how she managed and developed coping mechanisms to run a happy family as well as a very ambitious workplace. Concentrate on what counts. They have to learn to focus on the rest. Deal with the immediate issues first, then move on to amber, then move on to cream. You have to teach them to focus. And remember, especially as anesthesiologists, that there are a lot of moments of crisis. Calm. You have to stay calm, and you have to teach them calmness. It is contagious. Now, the mentor's roles can be varied from a sounding role where you can just sit there and listen to them, to a facilitator, a critical friend, advise them correctly, a networker. You can help them, get a place at some other institution after they finish their training, a coach, a role model. And remember, each one of this relationship is different. Now, it has a very big reflection. What it reflects in is improved clinical performance and improved patient safety. It really takes off the pressures of the trainee's mind. Implicit leadership is what is required by a mentor. You're there as a fallback system, not somebody with a stick, do this, do that. Now, how can that be done? That can be done by creating awareness programs like the one that we're having just now at this forum. By running GPSP, maybe you can run mandatory mentorship workshops. Like they have some mandatory workshops, they can add this one to it. I think it's a requirement of the day. Remember, mentorship is a whole education, a whole science, where people are developed into pastoral leaders, not just academic leaders. You need to be more than an academic leader. And the basis of this is unconditional positive regard and mutual respect. So I'll conclude here by this Rumi saying whom I love and the saying I love. Be a lamp or a light or a ladder. Help someone's soul heal. Walk out of your house like a shepherd. Thank you.
Thank you very much, Professor Saida Haider, for your very illuminating talk. Our next speaker is Dr. Faisal Shamim, who is a very enthusiastic and leading clinician working as consultant in aesthetic at an intensive care in Aga Khan University Hospital, Karachi. And he has got a special interest in critical care and airway management. He's going to talk about from subjectivity to objectivity. And here is Dr. Faisal Shamim.
Hello everyone, Assalamu alaikum. I'm very thankful to chair and co-chair of the organizing committee, and I'm very honored to speak at this prestigious 20th Shaukat Khanum Cancer Symposium. Very special thanks to Dr. Atiq, who has invited me for this talk. I'm Dr. Faisal Shamim, and I am Associate Professor and Consultant in Department of Anesthesiology, the Aga Khan University and Hospital, Karachi. I have some special interest in difficult airway management, regional anesthesia, and intensive care. I'm currently the Program Director of Critical Care Medicine Anesthesiology Fellowship, and I have been the lead person for developing departmental guidelines, member Difficult Airway Society UK, and founding director from Pakistan for International Airway Management Society. So my topic is subjectivity to objectivity. This is my disclosure. I have no actual or potential conflict of interest in relation to this program or presentation. And as you can see in the picture, that a tree, which is an objective reality, some have an exact objectivity and some have subjectivity, that it can give some money or give some fruits. So 5 centuries ago, Leonardo da Vinci stated that tears come from the heart and not from the brain. And because this idea could be used to describe the strategies over many decades to monitor the adequacy of anesthesia and to evaluate other effects of anesthetics and not just loss of consciousness. So perioperative monitoring, we know, is a subject of lot of research and development. There are standards by AAGBI and American Society of Anesthesiology, and the standard 1 is the presence of experienced and qualified anesthesiologists, and the standard 2 is the monitoring of pulse oximetry, ECG, NIBP, temperature, and then additional monitoring which requires like continuous invasive arterial blood pressure, central venous pressure, transesophageal echocardiography, neuromuscular monitoring, as they may be necessary deemed appropriate by the anesthesiologist. The first landmark advancement in monitoring technology occurred in 1980s when pulse oximetry is invented and introduced into the clinical practice. Over the last 2 decades, there is an increased number of medical litigation with subsequent increased attention to patient safety, which is coupled with the advancements in technology and have led to enhanced need for improved monitoring. The most clinicians in anesthesia, they have witnessed over the years that there is an even ever larger array of monitors and measuring devices have been introduced into their clinical practice. And each one of them claims that it can add a vital information to conduct a safe anesthesia and optimize care. The mortality directly attributed to anesthesia has reduced over the last 25 years. And the recent data on anesthesia mortality have come from the triennial report of Anesthetic Mortality Review Committee from Australia, which have shown that anesthesia has become safer over the last decade and over the time, and that the risk of death directly attributable to it in healthy patients undergoing minor or moderate surgical procedures is nearly 1 in 200,000. So many anesthesiologists cite improved monitoring as a reason for reduction in anesthetic related mortality over the years. So how we objectively monitor our patients during anesthesia? So this refers usually to display of both the monitoring patient's physiological variables and the monitoring of variables which assess the anesthesia machine function. The monitoring strategy has an acceptable predictive value. It can able to show what is currently happening, and it can able to alert the clinician of any potential critical or damaging event is nearby. The newer perioperative monitoring techniques are based on neurological monitoring, the goal-directed fluid therapy, there are advancement in alarm systems, and then there is technological advancement in perioperative pain assessment. So the first step change in advanced monitoring in perioperative monitoring is neurological monitoring. And intracranial pressure monitoring is continued to be an essential monitor in neurosurgery. The current measurement of ICP most commonly include a pressure transducer from either a direct fluid-filled system or a dedicated system that can be connected to a vital signs monitor capable of presenting the ICP as numerical values of mean ICP. Although the fluid-based ICP measurements are considered the most accurate, this measurement modality has several limitations, including complication profile related to its invasive nature, defining zero levels for fluid-filled catheters, and inaccuracy related to ICP source signals from the fluid-filled systems. There are some dedicated implantable ICP sensors which has been introduced in the clinical use in 1980s. These are reliable and accurate in clinical setting. The validity of parenchymal measurement has been thoroughly documented through numerous validation studies. The signals obtained are less prone to artifacts, and the validity is being documented. There are limitations like risk of bleed and infection, and they reflect the local pressure at the site. A criticism of the ICP sensors is that they reflect the local pressure at the site, which can be misleading as there are pressure gradients across the intracranial compartment, and hence the pressure within the skull is not uniform. So this has been an area of interest and recent research that monitors of cerebral oxygenation, and there are two types of monitors, which are imaging methods and non-imaging methods. The imaging methods are mainly positron emission tomography and magnetic resonance spectroscopy, but the non-imaging methods which are of interest to us are jugular venous oximetry, near-infrared spectroscopy, intracerebral microdialysis, and brain tissue oxygenation. Of note, the jugular venous oximetry is being used being commonly, and that has an adequacy of cerebral blood flow in relation to the metabolic demand of the brain. This is highly sensitive in the presence of global hypoxemia or ischemia, but again there are some limitations of risk and bleed and infection, and they reduce the local pressure at the site. The near-infrared spectroscopy evaluates the electromagnetic spectrum, where the photons are capable of penetrating deeper tissues, and they also capture changes to oxygenated and deoxygenated hemoglobin. So it has the capability of monitoring the regional oxygen saturation into the brain. The NIRS-based cerebral oximetry is being used increasingly in cardiothoracic and vascular anesthesia. It gives measure of predominantly oxygenation, which reflects the oxygen extraction. So monitoring and maintenance of regional oxygen saturation within 10 to 20% of the baseline has shown that it has reduced complications and improved outcomes. Depth of anesthesia monitoring is the second step change in the advanced perioperative monitoring. We know that the reported incidence of intraoperative awareness varies from 0.2 to 2%. And the first depth of anesthesia is bispectral index monitoring. The concept of depth of anesthesia is not new, but its definition is still debated, and reaching the consensus is unlikely in the near future. All depth of anesthesia monitor calculates an index or a value derived from the EEG, which can measure the hypnotic component of anesthesia, and it can help in detecting awareness by titrating the anesthetic agents, and it also keeps a balance between anesthetic requirement and anesthetic drug administration. There are a variety of depth of anesthesia monitors, namely BIS, entropy, narcotrend, and these monitors have been into the practice. BIS, we must have, most of us, we have commonly seen, but GE monitors and the General Electric machines and monitors have introduced entropy, so there is no need to buy a separate depth of anesthesia monitor, and you can put an electrode of entropy and you can connect with the entropy module through your GE monitor. So these are some specifications. I'm not going into the details of each of one. So there are some practical limitations in depth of anesthesia monitoring. They are not all validated to the same extent except the BIS. They have some clinical ranges which are not identical across the devices, and there is enough evidence that awareness can still occur even with depth of anesthesia monitoring. Although reduces the drug consumption and accelerate recovery, but it does not translate into early discharge or improved outcome. There is a large study in Australia popularly known as the Be Aware study, and clearly demonstrated that the use of BIS can reduce the awareness but does not prevent it with number needed to treat. Perioperative brain function monitoring. Now this has come recently and there are multiple clinical examples where the brain or the central nervous system in general is the diseased organ, and clinicians try to focus on monitoring brain function as a means to guide treatment and prognosis. The rationale for brain, there are some conditions like traumatic brain injury, subarachnoid hemorrhage, hypoxic brain injury, conditions which are directly related to neurosurgical interventions. So most technical devices which use to monitor a patient state during anesthesia are based on distinct physical principle of measurement. And these physical principles of commonly used brain function modalities are EEG, evoked potentials, near infrared spectroscopy, and transcranial Doppler. Each of one has a physical principle, each of one has clinical utility. I'm not going into the detail of each and every one. Some has limitations, some are very important, like EEG can titration of anesthesia, there is burst suppression. The NIRS can monitor the regional cortical hypoxia, hypoxic reserve, but no single monitor provides definitive information regarding the overall integrity of brain function and its homeostasis in the perioperative setting. Now, a more meaningful approach, however, would be to look at how measures of different qualities of brain function, when put together, can optimize patient care, so that there is a challenge of combined monitoring. Schneider and colleagues, in an experiment where a combination of electroencephalographic and middle latency auditory evoked potentials parameters were used to differentiate between a state of consciousness, and they have shown that higher prediction probability than BIS alone for clinical separation between consciousness and unconsciousness. Now, the same group of researchers devised a composite like anesthesia multimodal index of consciousness, which is used a stepwise classification and adaptive neurofuzzy inference system. They showed a significant higher prediction probability to separate various levels of consciousness, unconsciousness from wakefulness to burst suppression. The third step change is the new developments in hemodynamic monitoring. And the new hemodynamics monitoring these are the non-invasive device to measure cardiac output and stroke volume in anesthetized patients. There is a move from static to dynamic measurements. The waveform analysis of the pulse oximeter, waveform analysis of the pulse contour is used to calculate stroke volume and cardiac output, and then they have an effect of respiratory variation on this waveform has been used to estimate fluid responsiveness. The goal-directed therapy guided by dynamic variables are pleth variability index, pulse pressure variation, and stroke volume variation. The pleth variability index is a measure of dynamic changes in the perfusion index that can occur during one or more complete respiratory cycle and is measured during pulse oximetry. So pulse pressure variation or pleth variability index greater than 13% is highly predictive of fluid responsiveness in mechanically ventilated patients with sinus rhythm. Goal-directed fluid management using pleth variability index has been demonstrated to reduce perioperative lactate levels compared with standard measurement include central venous pressure, blood pressure, and fluid chain. So we move our transition to minimally invasive and non-invasive hemodynamic monitoring techniques. We were using the pulmonary artery catheter as a gold standard for measuring cardiac output, mixed venous oxygen saturation, and then we moved to less invasive where cardiac output monitoring using arterial pressure waveform analysis or esophageal Doppler. And now we have going and approaching a completely non-invasive methods of hemodynamic monitoring, which is volume clamp using finger cuff, bioimpedance, carbon dioxide rebreathing, and pulse wave transition. In last 1 decade, there are numerous studies which have been performed with esophageal Doppler guided cardiac output guided fluid strategies. Goal-directed fluid management using pleth variability index has been demonstrated to reduce perioperative lactate levels. So esophageal Doppler cardiac output monitor measures blood flow in the descending aorta via a flexible Doppler probe introduced into the esophagus of the anesthetized patients. Measure the stroke distance, that is the velocity time integral, which is then used to estimate the stroke volume. The limitations is that it has only in 37% of patients where decreased stroke volume perioperatively respond to the fluid bolus. An absolute measurement may also vary by 40%. The pulse contour analysis, which transfers a pressure signal, the arterial pressure waveform, into a flow signal, and it drives the stroke volume from the pulse pressure of the arterial pulse waveform. Amongst the less invasive hemodynamic monitoring technologies, those based on PCA are the most broadly used, and the system derives stroke volume from the pulse pressure of the arterial pulse wave after correcting for the compliance and the resistance of the vasculature. The volume clamp method using finger cuff, this relies on photoplethysmography to keep the finger blood volume constant. Arterial pressure waveform can be reconstructed. Cardiac output can be calculated using a devised algorithm. Studies examining the cardiac output estimates by this method show a percentage error from 24% to 58%. So integrative concept for the use of cardiac output monitoring devices. So we move from pulmonary artery catheter. So there is an ward, then an ED, in OR, and in ICU. Considering the technical features and typical limitations of the different cardiac output monitoring techniques, it is obvious that no single device can comply with all clinical requirements. Taken in summary, these minimally invasive PCA-based technologies have accuracy with a percentage of 2.7%. There is also introduction of artificial intelligence to predict hemodynamic changes. And there is this artificial intelligence has been the machine learning, big data, predictive analytics, and they have a development hypotension prediction index, which is a development of an algorithm to predict an upcoming hypotensive event. And how they recorded and how they measured is that 13,000 past hypotensive events and 12,000 non-hypotensive events, they derive from high fidelity arterial waveforms from 1,700 patients. Each of the arterial waveform were first separated into 5 phases. Then 3,000 waveform features were identified. Then these combined these individual features, and then 2.6 million features were obtained. So hypotension prediction index, the results showed that this algorithm was able to predict hypotension with high sensitivity and specificity up to 15 minutes before the actual hypotensive event occurred, and that it performed better than changes in mean arterial pressure did. Additional successful examples of the use of machine learning based algorithms in the field of anesthesiology include the prediction of complications after surgery such as sepsis and AKI, the prediction of mortality after cardiac surgery, and the prediction of post-operative pain and associated resource consumption. One of the important monitor is on the point of care testing, which we would like to do in the operation theater, is non-invasive continuous hemoglobin monitoring. And the non-invasive hemoglobin monitoring is a more recent introduction to the growing list of point-of-care testing capabilities. The most commercially available devices rely on spectrophotometry. This is the Radical 7 RAD7 pulse co-oximeter capable of measuring hemoglobin concentration using a non-invasive multi-wavelength sensor, which is a spot check and also has a continuous ability. There is some variation in the basic principles that govern the functioning of most commercially available non-invasive devices. So accuracy of non-invasive hemoglobin monitoring. The first study to look at the accuracy was performed by McNett et al. They have taken 28 subjects which underwent a hemodilution protocol and phlebotomy of 450 cc blood. The hemoglobin measurements by lab co-oximeter in subjects undergoing hemodilution and surgery. Data points compared with RAD7, and then using 458 data pairs, the authors demonstrated a very strong correlation coefficient of 0.9. Avada et al. Examined 106 patients undergoing neurosurgical procedures, and then there is a control group which has standard invasive hemoglobin monitoring by intermittent sampling. The study group had hemoglobin monitoring non-invasively by pulse co-oximetry, and the peripheral hemoglobin or the non-invasive hemoglobin had fewer units of blood transfused. The new perioperative monitoring has also been focused to objective monitoring of nociception and pain assessment. There are technological advancement in perioperative pain assessment, and the nociception monitors could be integrated into a closed-loop systems for the administration of analgesics and identification of patients with higher likelihood of severe postoperative pain, and they may allow more targeted preemptive analgesia. So quantification of nociception in unconscious subjects is extremely difficult, but reaction to nociception that is being used for the purpose of monitoring can be done. So the technological advancement has been there. So we know that whenever there is a surgical stress, there is an increased sympathetic activity, there is nociception, and there is a trigger shift in the sympathovagal balance, which can affect on increasing the heart rate, vasoconstriction, pupillary dilatation, and then there is a heart rate variability. And so this can be objectively monitored in the operating room. The most commercially available monitors are based on the detection of one or two parameters. The single parameter scores are analgesia nociception index, skin conductance, pupillometry, nociceptive flexion reflex. The two parameter scores are surgical pleth index. The analgesia nociception index is a 0 to 100 dimensionless score, which is calculated from the assessment of the heart rate variability, and the higher analgesia nociception index shows higher parasympathetic activity and less pain and nociception. The pupillometric assessment of nociception, which is called LG scan, is the assessment of pupillary. The pupillometric has shown some promising results. The assessment of pupillary diameter, its variation, and its unrest in ambient light have been examined for prediction of pain, intraoperative monitoring of nociception, postoperative pain in post-anesthesia care unit, and pain in the ICU. This has shown some promising results, such as reduction in persistent postoperative pain. However, the method is influenced by several significant confounders like opioids, and all studies available to data are relatively small. The surgical pleth index is a special proprietary score in the GE monitors, and this has sought to be calculated from the pulse phase amplitude and the heartbeat interval. The quantifies the intraoperative pain using photoplethysmography acquired from an index finger, and the recommended range for intraoperative surgical pleth index is less than 50. The lower values show lower stress, and that shows a lower response and lower nociception and lower pain. So to date, no evidence exists for a clinically relevant benefit of an ANI monitoring or the surgical pleth index monitoring. The usefulness of surgical pleth index guided analgesia during general anesthesia. This is a systematic review and meta-analysis of randomized controlled trials. So surgical pleth index guided and compared the surgical pleth index guided and conventional analgesia 6 randomized controlled trials comparing 463 patients were included. The surgical path index guided analgesia can reduce intraoperative opioid consumption and facilitate extubation. So in conclusion and outlook, in this day and age, clinicians and researchers are an outcome-obsessed community. Each new drug, technical innovation, and clinical adjustment is judged against the presence or absence of outcome effects. When appropriate management is individualized by using appropriate monitoring and timing, clinical decision making and efficacious modifications can occur and the outcomes positively and improve patient care. Thank you for your time and attention, and any questions, I'm available.
Thank you very much, Dr. Faisal, for a very informative talk. And let me introduce our next speaker, a friend of mine, Dr. Syed Raza Mehdi, who is my colleague, consultant anesthetist at Shaukat Khanum Memorial Cancer Hospital, Lahore. He is a dual accredited and qualified anesthesiologist from Pakistan and from Ireland. He is a fellow of the College of Physicians and Surgeons, Pakistan, and a fellow of the College of Anesthetists from Ireland. He has got special interest in total intravenous anesthesia and anesthesia and the cancer recurrence. He is going to talk about learning from controversies. Over to Dr. Syed Raza Mehdi.
Good morning. So what am I going to do today in this session is to talk about something about the controversies in scientific field, or to be precisely controversies in anesthesia. So to start with, I'm Dr. Mehdi. I'm the anesthesia consultant in Shaukat Khanum Hospital, Lahore, and we are going to talk about the controversies. To start with, first, the controversy is a prolonged public dispute or debate concerning a matter of opinion. This word actually originated from the Latin word converse, and which actually means they turned against. So what I'm going to talk about now is, as we have started with the concept of the controversy and the paradigm of learning from controversies. And we will also briefly discuss some of the controversies in anesthesia, the classical controversies and more recent controversies, and how can we learn better from our controversies. Why we need to discuss. So first, as we discussed what's the controversies, then the dynamics of the controversies, and we'll briefly touch upon the idea of controversy as in a social physics level. And actually, they are bound to happen when with the advancing knowledge. And the other problem usually happens is the advancing academic setting to a real work practice. This transition also generate controversies. And then at the end, I just want to touch briefly about the concept of law of marginal gains. So the dynamics of the scientific controversies are, broadly speaking, relate either to ethics or need for further research or a policy decision on the basis of incomplete information. The key is effective communication about the fact and the processes of the ongoing controversies and how we are going to process all this information and the new development. Effective communication is the key word for reducing the element of controversies. Just when you're dealing with, there's few challenges, and we should keep in mind that the current accepted term as a accepted dogma is actually a moving target. The truth is usually an amalgam of our best and imperfect understanding of the issue, while just keeping in mind the publication bias, which is actually the negative result that are not easy to publish. When we are trying to do the oversimplification to produce a clear bottom line or a take-home message, we may lose some important points. However, it's an effective tool in gaining peers' attention. This is a classical picture of a surgery in pre-anesthesia era, and these sort of surgeries, the procedures, may involve up to 300% mortality. But still, when the anesthesia started, it was a controversy to start with. This is a famous picture from the ether day, first use of the ether in Boston, and still it was a controversial debate afterwards when this public demonstration was done. Queen Victoria used the anesthetic medication for the labor analgesia, but still, after this publication, it was still a controversy. Some of the social physics aspect. This is a picture which we as anesthetists are very familiar with about the flow, which may be laminar or turbulent. And this is a very common picture we see in our textbook and in the articles. And how is the advancement of the flow? You can see some of the layers of this fluid advancement are a bit in advance than the layers which are to the periphery. That's how it happened in a smooth way, and the advancement of the science developed. But sometimes, either because of the rapid flow or because of the diameter of the tubing, it becomes turbulent, and the different layers of the societies, they got into conflict how to advance, which lead into this turbulent flow, which is actually we don't want. But it is going to bound to happen when we are doing for rapid transition from one place to the other place for a recent advancement. The classical controversies we have seen in anesthesia is, as I mentioned, anesthesia started with controversies. Nitrous oxide, hero or villain, this is a classical old discussion still going on. The great fluid debate, which fluid to prefer. And then what's the better option, regional or the general anesthesia? Or the other issue is, should we remain an anesthetist or try to become a perioperative physician? ERAS has come with a big bang initially, but still people are questioning, is it an effective tool in betterment of the patient? Then comes the prehabilitation. Does it improve the outcome? This has been questioned, and we will just briefly discuss these topics as well. So to start with the first one, should we become a perioperative physician instead of an anesthetist? Should we move to become a perioperative physician? Should it be considered as an evolution of anesthesia practice? Or it is just a stretching oneself too far in clinical field? Actually, one version or one aspect of the perioperative medicine is, this is basically evolution of anesthesia from focus of the OR management to a care of a patient from decision of surgery taken to the discharge from the hospital. From maintaining vital organ function to comprehensive medical care during, before, and after surgery. From surgery enabling service to a perioperative science. Keep in mind that as we are advancing, we are getting more of these morbidity-ridden patient population coming to the ORs. So this sort of aspect is bound to happen. To start from the first aspect, if we can start with the preoperative controversies. The first one is the perioperative anemia. How low hemoglobin is acceptable to us as an anesthetist during the care of this patient? How can we do the pharmacological management of the, rather I should say, how to minimize the minimize the cardiac risk on the pharmacological basis, and to start the prehabilitation while we are still, the patient is still in the preoperative assessment clinic, just to keep in mind the question, can it make a difference? Preoperative anemia is prevalent in 40% patient of the surgical population, and while dealing with the cancer surgery, figure goes up to 56%. And one of the WHO recommendation is that patients should get pre-optimization if the blood loss is expected to be more than 500 mils or the hemoglobin is less than 13 grams per liter. Then the concept of the patient blood management comes up, which means that optimization of the red cell mass, minimization of the blood loss, while managing the post-op anemia as well. All this concept of the management of the blood deals with the economics of the blood transfusion. When we're talking about the economics, I'm not just mentioning the cost of the blood transfusion. I'm talking about to deal with the complication and side effect of the blood transfusion as well. We have seen this evolving approach to deal with the anemia from the oral iron to the iron dextran and then to the iron carboxymaltose, or we can still stick with the traditional old concept of red cell transfusion. The number of medicines which has been used perioperatively, starting from the erythropoietin, there's a debate, do it or not to use it, and then transaminic acid, alpha aminocaproic acid, or the protein, when to use, what to use. This is a debate which is keep on going, especially keep in mind the recent trials of CRASH-2 trial and the BART trials about the protein, and the CRASH-2 about the trauma patient when the transaminic acid was used. So these are the ongoing debates, and some conclusion, especially in terms of the protein which came in, then went out, and now coming in again. Other issues with this blood management concept is the transfusion trigger. Okay, this is the classic, become a classical study, the TRICE study, or we have moved to a NICE guideline, which we'll briefly discuss. The point is when to start the transfusion. That's an important thing, which we okay, I'm not talking about the controversy, but it is becoming a debatable issues when to start it. And then we come to the concept of prehabilitation. Is it beneficial? Actually, it's the process of enhancing patient functional capacity. The aim is to improve the post-op outcome, especially when we're dealing with the high-risk subgroup, the elderly, patient undergoing major surgeries, multiple comorbidities. Just keep in mind that the 12% of the surgical population admitted, they actually amount to 12% of the surgical population, but still they amount to 80% of the post-operative deaths. Can the medical optimization, the physical exercise, the nutrition support, or the psychological support, can they improve the patient outcome? This is the ongoing debate, and some people are using this concept, while some people are still looking for the evidence. One of the best evidence in this regard comes from the actually cancer patients, especially those cancer patients who has got a dual hit cancer treatment going, already have new adjuvant and now coming for surgical treatment. So they are the one who usually get the got the evidence for the rehabilitation benefit. And regarding the different cancer surgeries, the breast and the rectal cancer surgeries have shown some evidence of importance of doing the rehabilitation, which actually start with the preoperative status of those patients. This is again the concept of the enhanced recovery program. Although it came up in the last century with the Big Bang, and they start with the people started about it, but then the different approaches comes up, and some people start questioning the benefit of the enhanced recovery programs. So okay, so they're still debating. And then just keep in mind, broadly speaking, the enhanced recovery program is the starting of the different points at different point level, which are talking about the managing the pre-op anemia, the perioperative blood management, the optimum level of hemoglobin at the discharge, the VTE risk and the VTE prophylaxis, the concept of the minimizing the post-operative delirium and cognitive dysfunction. Then we come to the post-op, this issue of post-op orthostatic intolerance. There are different factors which govern, and we want to minimize this. The post-op pain management after major surgery, keeping in mind the hope of replacing opioids by multimodal opioid-sparing analgesia. Epidural analgesia is still a good one. Recent used extensively and still been used, but the current evidence do suggest does not use as a routine in many operations. High dose preoperative steroid administration, it allows for the improved pain relief and reduces the inflammatory response and the early fatigue. Then comes the concept of the role of rehabilitation and the post-op physiotherapy, how to use or when to use. This issue of cancer anesthesia, can the anesthesia and cancer surgery affect recurrence? Just keep in mind, the cancer is a key cause of morbidity and mortality worldwide, and this overall incidence is on rise. There is at least some experimental data suggesting that surgery, and to some extent the general anesthesia, acute post-op pain and opioid analgesia may accelerate the tumor growth or the risk of metastatic reoccurrence. Especially these few of the anesthesia drugs which have been mentioned here are under close examination, and with the experimental and clinical data still awaiting, but they are under close scrutiny as a possible culprit in this regard. But only the prospective randomized clinical trial, which we still does not have, can prove a cause and effect link between the different anesthetics and the cancer recurrence. There's the concept of the evolution of the acute to chronic pain. The incidence overall is 1.5 to 10%, but it varies up to 50% depending on the type of surgery. The perioperative plan starts with the identifying pre-op pain status, the anxiety, the age of the patient, and the type of surgery. These are the four major factors in these transitions. In this regard, we have to deal the opioid tolerant patients with a special category and don't jump into the conclusion of weaning those patients in this perioperative period. The key factor in all this management and prevention of the acute to chronic pain transition is the multimodal analgesia. The perioperative multimodal analgesia is the use of different classes and different sites of the analgesic administration. It enhances recovery and hospital stay. The local anesthesia with the multimodal analgesia, for example, NSAIDs, the opioids, the CNS modulators, they reduce this transition of this chronic pain. And interestingly, the sevoflurane, the TCI propofol, nitrous oxide, and ketamine, they do help in development of the chronic pain. Rather, I should say, they do contribute to the development of the chronic pain. In this regard, I can say they are under investigation, and hopefully they will come up with some solution with the use of these drugs. Then another concept of this quality of recovery scoring is a good concept. Still, people are still debating the validity and the importance of this concept, and different scores can be used. It's basically this, I can say it's a short-term reinstitution of the physiological parameter to a multimodal concept. The physiological, the nociceptive, emotive, functional, or cognitive improvement. This is the return of the patient function to his own baseline. It assesses in different domains and the time point. The question is still under investigation and a discussion with different studies. How many questions or how many versions are enough to assess the quality of recovery, moving from the 40 questions to the 9 questions. And then I'll briefly touch about the regional anesthesia. As I mentioned, the classical debate about which one is the better option in terms of the patient well-being, post-operative improvement, and the less of mobility perioperatively. Then the other debate which has been going on in anesthesia regarding the general anesthesia is the size of the needle used in spinal or in epidural practice, and the concern about the post-dural puncture headache. Interesting literature has come up recently about the incidence of the PDPH and the shape of the needle tip or the size of the needle tip. So these are classically been studied in the obstetric anesthesia practice, but the orthopedic anesthetists differ regarding terms of the size. They don't agree with this idea of the shape of the needle tip or the size of the diameter of the needle do contribute. That it does not contribute to the post-dural puncture headache or the mobility regarding these epidural concept. In summary, what I can say is the learning from the controversy is a way forward in the scientific development, and we have to agree or disagree from the for the advancement of the anesthesia. We have to bring together the academic setting to the real world practice, which might minimize this controversial effect. And then comes briefly about the law of marginal gains. Just keep in mind that we are not going to get a big change in our academics or the clinical practice. Small changes, when combined, can contribute to a big change or big development of the anesthesia practice in our clinical setting. And that's all. And that's I finish my presentation. thanks for the listening and might be getting into some comments and the discussion. Thank you very much.
Thank you very much, Dr. Sayyid Raza Mehdi. And now we have our most distinguished speaker. We are lucky to have Dr. Arif Hussain with us. He is one of the pioneers and the leaders of the point of care ultrasound. He is the present head of the cardiac critical care at King Abdulaziz Medical University, Riyadh in Kingdom of Saudi Arabia. And he is the immediate past president of the WinFocus, which is the World Interactive Network focused on critical ultrasound. So over to Dr. Arif Hussain. He is going to talk about point of care ultrasound in anesthesia.
Bismillah ar-Rahman ar-Rahim. I would like to thank Dr. Asad and Dr. Kashif for the invitation to speak in this symposium, which is a great honor for me, on point of care ultrasound or POCUS in anesthesia. I'm Dr. Arif Hussain, and I work in Riyadh, Saudi Arabia as a cardiac anesthesiologist and intensivist. I have no disclosures other than my association as president of WinFocus, which is an international ultrasound society. If you look up point of care ultrasound in PubMed, you'll see that there has been an explosive increase in the research and publications on this subject in the recent years, and that's why it is a hot topic. A great number of publications have emphasized the need to adopt point of care ultrasound in the training of perioperative medicine, i.e. anesthesia and critical care. This is the latest article, which is still in press for the Red Journal, pointing out the POCUS applications that the cardiac anesthesiologists need to learn. And it is also accompanied by an editorial that stresses the need for proper training and competency. I also refer you to this paper by Feroz Mahmood for a more detailed list of POCUS competencies and curriculum recommended for the anesthesiologists. For a complete discussion of the topic, we need to consider many aspects of POCUS. Teaching, learning, and curriculum are particularly important for development of competency in it. This list is not exhaustive, but generally this template is used for guideline production. In the limited time, I'll just discuss the first three briefly. We must first define POCUS because definition will set the framework within which the clinician operates. So what's POCUS? Limited use of ultrasound, usually performed by non-sonographers or non-imaging specialists, to address specific questions related to patient care that need to be answered at bedside. In essence, it's an exam performed by the treating clinician, narrow in scope, problem-based, goal-directed, and it tries to answer defined clinical questions. It's time-sensitive, meaning the patient's life may depend on the information. It has to be simple. It provides mostly qualitative, but if needed, more sophisticated quantitative data can also be produced. Perhaps the most important point is to recognize the limitations of this examination or the limitations of the operator or the equipment used. Anesthesia is a very broad field, as we all know. And where we can apply point of care ultrasound is wide open. Preoperative ultrasound enhanced evaluation could include screening for cardiovascular and respiratory disease, difficult airway prediction, prandial state assessment, predict hypotension at induction of anesthesia. Similarly, we can enhance the patient care with POCUS in the operating room and then in the post-operative units, especially dealing with the emergency situations. Ultrasound is not new to anesthesia practice. vascular access, ultrasound-guided nerve blocks, and transesophageal echocardiography are well-established ultrasound applications in anesthesia. I'm going to skip these in this presentation and speak about other useful applications in the perioperative medicine. If we adopt a multi-organ or whole body approach, focus becomes a very powerful tool. Ultrasound applied with the whole body approach has essentially reshaped the physical examination. These are just some of the organs we regularly interrogate or insonate to assess the patient condition. I'll just pick a few fun applications out of them in the limited time we have. Let's start from the top. Unfortunately, in spite of all the progress in medicine, we still encounter cardiac arrest and anoxic brain injury issues in anesthesia and ICU. Transcranial Doppler and the optic nerve sheath diameter measurement allows us to estimate intracranial pressure non-invasively and can predict the neurological outcome. Probably the most important target in POCUS is the heart. Actually, the use of echocardiography in the perioperative period is not new. We started using transesophageal echo in the OR and ICU more than 30 years ago. Even the early publications suggested that TEE gave additional information when pulmonary artery catheter was also already in place and revealed the diagnosis in a number of critically ill patients that led to a change in therapy. And the same applies to transthoracic echocardiography. Just a few studies out of literally thousands are mentioned here that show its value in the care of a critical patient. Point-of-care transthoracic echo changes management in a significant proportion of critical patients, especially when the clinical picture is unclear. Even the portable ultrasound machines significantly add to the management of patient care. In critical life-threatening scenarios where the blood pressure is sinking, ultrasound can reveal pathophysiology requiring very different treatment in each case. Left ventricular failure, cardiac tamponade, acute cor pulmonale, possibly from pulmonary embolism, or hypovolemia. When cardiac ultrasound is combined with other sonographic clues, a pattern emerges, allowing the pathology to be recognized immediately. This pattern recognition is very similar to facial recognition that is done with a software. Here, the example of hypovolemia, the cardiac picture is supported by the collapsing inferior vena cava with each inspiration. There are 6 commonly recommended targets that can be used as a guide to the cardiac exam, not only in the context of shock and cardiac arrest, but some of them are relevant in the perioperative period as well. We can check out the left ventricular, right ventricular function, volume status, pericardial effusion, look for signs of chronic heart failure, and gross valvular abnormalities and masses in the heart. If we can train our eyes to recognize these 3 shades of left ventricular function, normal, moderately depressed, and grossly poor, we can avoid many unnecessary cardiology consultations. Left ventricular dysfunction can be subtle, and since this conference is related to the cancer patients, I'll use this case as an example where more detailed exam is triggered by observation of effect of chemotherapy on a breast cancer patient that could constitute an anesthetic risk for surgery. This not so good ejection fraction by focus exam prompted comparison with the previous echo studies. The circumferential contractility doesn't appear to be much different here between the 2 images. And often that is the case where function must be objectively evaluated in long axis views. assessment of function in these apical four-chamber views is more sensitive in the same patient 2 years apart. So the POCUS prompted a thorough evaluation and a review of the cardiac function and chemotoxicity in this patient. And this is given an objective measure by using strain and accurate ejection fraction by Simpson's method. Normal global strain is considered to be a number greater than -18%. By the way, these measurements can be made by the bedside and may be considered advanced POCUS. So both global strain and ejection fraction show moderately depressed LV function globally. Previously, the function was normal, both by the strain and ejection fraction as shown here. This information may be quite important for the anesthesiologists who are planning an anesthetic for a particular operation. Another common finding in certain cancer patients, for example, in lymphomas, is pericardial and pleural effusions. If you notice, the aorta is labeled in the right clip. The fluid below it is pericardial fluid, and that's a good clue to differentiate between different types of effusions. Rate of accumulation is usually slow in cancer patients, and the pericardium is able to gradually stretch and accommodate a large volume without creating tamponade physiology. Whereas acutely and rapidly accumulating effusion can cause cardiovascular collapse. Almost on a daily basis, we are confronted with the question to give fluid or not to give. We can easily devote a whole lecture on it. This is an example of post-op hypotension that can happen in the ICU or PACU. With a blood pressure of 77 and tachycardia, the pattern of collapsing inferior vena cava with inspiration is obvious. Simply by giving increments of fluid, one can monitor the change in blood pressure, heart rate, and filling of IVC. So here, POCUS can turn into a monitoring tool as well. In the ventilated patients, it's more difficult to assess the volume status, and that's where we must use the dynamic measures to assess volume responsiveness, meaning that the patient will respond to fluids by raising his cardiac output depending on where he is sitting on Starling curve. These are the responses to heart-lung interactions, passive leg raising, or actually giving a fluid challenge, usually a mini bolus of fluid over a short time. The response to mechanical ventilation is gauged by the change in Doppler measured velocity profile through the left ventricular outflow tract. This change in peak velocity, delta V, serves as a surrogate of change in the cardiac output with each mechanical breath. The cutoff values have been established, which serve as a guide to giving more fluid. One of the best tools to monitor the excessive fluid administration is lung ultrasound. If the oxygen saturation drops and diffuse laser-like vertical lines start to appear in large numbers, you have to refrain from giving more fluid to the patient. Chronic fluid overload assessment or venous congestion that indicates right heart preload is done by Doppler profiles of hepatic and portal veins, and combining them with the renal artery and venous renal vein patterns. This is called venous access ultrasound, or VEXUS. This bedside technique has recently drawn a lot of interest. Let's move to the upper airway and lung. If you have a patient with hoarseness or experiences choking after anesthesia with endotracheal intubation, especially after thyroid surgery or coarctation of aorta surgery with possible injury to the recurrent laryngeal nerve, it is worthwhile checking the bilateral cord mobility. Trachea is normally filled with echogenic air and can be identified easily. real-time assessment and equipment in the and the size of the tube can be selected for intubation, which is the next step. Alan Sustek's paper from 2008 devoted actually showed that the tracheal width measured on the ultrasound image could predict the diameter of trachea and left main stem bronchus accurately, and thereby choosing the correct size of double lumen tube for surgical needs that would pass easily and isolate one lung successfully. Esophagus lies between trachea and pulsating carotid artery and may appear as a bullseye. Sometimes you have to locate it by asking the patient to swallow. If the endotracheal tube inadvertently ends up in the esophagus, it is readily apparent, and it appears as if there were two tracheas that you can see in the right image. The transverse scan of trachea reveals the appearance of tube, and if viewed in the longitudinal plane, we can also estimate the depth as well. And this can be helpful in the pediatric cases, as shown by this paper, where they check the cuff position by placing the ultrasound probe at the sternal notch with 95% accuracy. Once intubated, bilateral lung inflation can be confirmed by presence and movement of the pleural and other sonographic features of the lung. Presence of A lines or B lines that move with the mechanical ventilation of the lung. In addition, diaphragm movement bilaterally and appearance of the lung, called the curtain sign, further confirms that both lungs are being inflated and the endotracheal tube, in fact, is in the correct position. In single lung ventilation, there is a lack of sliding. And in case of esophageal intubation, one would find lung pulse, which is the cardiac pulsation in the deflated lung, shown by the white arrows in the right image. This study demonstrates a better sensitivity and specificity approaching 93 and 96% when ultrasound is used for proper endobronchial placement of the tube compared to auscultation with stethoscope. Identification of tracheal rings in the bigger and more anterior cricoid cartilage is very useful in performing cricothyroidotomy or percutaneous tracheostomy. Studies have shown that ultrasound-guided procedure is as safe as bronchoscopic technique. Similarly, simple identifiable patterns of lung pathology that we commonly encounter in the perioperative period. A pattern is normal, while the B pattern may be found in many pathological conditions. C pattern indicates collapse and consolidation, and pleural effusions can be easily identified with ultrasound. Lung ultrasound is almost as good as multislice CT in many conditions, including COVID, as we recently discovered. Of course, the often dreaded possibility of life-threatening condition of pneumothorax. The sensitivity in the presence of lung sliding, lung pulse, B lines, and C pattern is almost 100%, meaning no pneumothorax, and specificity of 100% when a lung point can be demonstrated. Gastric scanning is important for determining the perennial state of the patient in order to assess the risk of aspiration. This can be performed with the patient in supine or right lateral position with a curvilinear probe in the sagittal plane and the marker pointing towards the patient's head, and the antrum is pointed here. On the left is an empty stomach. In the middle is a stomach filled with fluid, and on the right is a stomach with semi-solid or solid food. Recently ingested food often also contains air and has characteristic sonographic appearance of echogenicity, and sometimes even an A pattern can appear, which we saw in the lungs. In this fluid-filled stomach, the next step is to figure out the area of antrum by tracing the serosal border of it. Nomograms have been constructed, which take into account the age of the patient and the gastric antral area to estimate the volume of the stomach content. The validation of the calculation model has been published by Perlas and his colleagues using the formula shown on top of the slide. Some useful applications in the urinary tract. Renal and bladder ultrasound offers interesting information in our patients. Resistive index or simple pathology that can pick up findings like cysts, hydronephrosis, and calculi, or find a full bladder requiring a catheter or a large prostate. Urine volume in the bladder is easy to measure by using a simple formula. Multiply the 3 dimensions and divide by 2 gives you the volume. And you can also use an automated 3D application, which is available in a small handheld device as well. Here, the urinary catheter can be easily confirmed by presence of the balloon and by injecting some air in the bladder. So this was a broad overview of some of the applications of POCUS relevant to anesthesia. To conclude, point of care ultrasound is ubiquitous, and it has permeated into every specialty. We just have to learn and teach it properly, specific for each specialty, including anesthesia, and it is easy to learn. Is it really easy to learn? Well, I'll leave you with this study showing that the 8th grade students could also learn basic skills of POCUS. I thank you very much for your attention.
Thank you very much, Dr. Arif Hussain, for a very informative and very illuminating presentation as ever. I wish we could have a whole session with you about the point of care ultrasound, because that is the future, when I can foresee that instead of stethoscopes, the doctors would be having the handheld ultrasounds in their pockets. So we come to the question answer sessions, a quick one. And the first question is by somebody from for Dr. Umar Farooq Khwaja, and that was about the video debriefing session. You might have read the question as well, that how effective is it and how ideally it should be done.
Mm-hmm.
Kindly unmute yourself, Dr. Omar.
Yes, sorry, thank you. So I think it's a very good question. I have used video debriefing myself, and I think it has got a big role in effective debriefing, but it has to be used in the right way. Where I found it to be most useful was in understanding the team dynamics and showing the leadership and management. So whenever a team was working, we used to replay important aspects through the use of video debriefing. But I have, on the other hand, seen sessions where they replayed all of the video, and that was not a debriefing, it was sort of a replay session. So we have to be careful. We have to be, a debriefer has to really focus on which aspects have to be shown and link it with the learning objectives, which again are the primary learning tools for the any simulation session.
Thank you very much. The next question is about what goal-directed therapies would you suggest in a resource-deficient peripheral settings in Pakistan, like in Tehsil headquarters and in district general headquarter hospitals? Dr. Faisal, please.
Thank you for asking this relevant question. Actually, when we talk about a goal-directed therapy monitor or a hemodynamic monitor, and when we see our Tehsil headquarters and very low resource hospitals, so I mean one of the most relevant is the pulse pressure variation through the pulse oximetry, or at least an arterial line with a pulse pressure variation. Now I know that our hospitals are not equipped with those, even with those basic monitors. But when we talk about LMIC, we also talk about tertiary care hospitals, secondary care hospitals. So at least to me, an arterial line with a pulse pressure variation is one of the minimum hemodynamic monitoring that can be used for outcome, for improvement in outcome in our patients.
Thank you very much. The next question is to Dr. Arif, please. That would you please kindly advise that do you think that the POCUS has nearly replaced the PA catheter in cardiac critical care, or else there is still some role of PA catheter considering risk benefits associated with the PA caths, please?
Well, it has definitely helped. The echocardiography or the ultrasound has definitely helped us understand the physiology or the pathophysiology of the cardiovascular issues in a different way by looking at many aspects of the heart. So it's a paradigm shift in assessing the cardiovascular system in a different way and getting used to it. Along with it, many applications of echocardiography actually help you measure many pressures and information that you got from pulmonary artery catheter. Is almost all of it is available. The problem is PA catheter is provided beat to beat or continuous monitoring, and also stayed with us for a long time and really showed no benefit and outcome, although there were reasons for not getting benefit from their use. The point of care ultrasound has not replaced PA catheters. Sometimes we need to use them, especially in complex cardiac patients where you need to monitor, for example, pulmonary artery pressures, and you're giving therapy to treat pulmonary hypertension, for example. But by and large, in our daily practice, at least in my ICU, very rarely we have PA catheters. And I grew up in an era where we could do no major case without a PA catheter. So it's a big shift. And at times I feel, and I do put in PA catheters when I need additional information. So to make the answer short, it has not replaced it. It is complementary, but it is extremely useful having these skills in point of care, echocardiography for cardiac assessment. And along with it, just to give me another 30 seconds, there is additional information when you have a probe in your hand. You have the additional information that is complementary. For example, what are the lungs doing? What is the fluid status in general? Is there another like hematoma somewhere that you can diagnose, infection, pleural effusions? There's a whole bunch of things that come which have nothing to do with PA catheters information providing capability. So it is a multi-system, multi-modal, multi-organ device in your hand that you can use to integrate the information to make the best judgment.
Thank you very much, Dr. Arif. A very quick question to Professor Saida Heather is that we basically aim for knowledge, skills, and attitude in our residents, in our trainees. So as far as the knowledge and skills are concerned, we are imparting that. So how far as a mentor are we contributing towards, or are we responsible for the attitude, for the development of the right attitude as an anesthesiologist among our residents?
Unmute.
Kindly unmute your mic, Dr. Saida.
Is it okay? Is it unmuted?
Yes.
That's
okay.
Fine.
Okay, I think I touched upon that in my talk, that CPSP is totally oblivious of this word mentorship. Unfortunately, we are just expected to be supervisors and that's it. And it's a very individualistic approach that some of us have as mentors. Otherwise, I really think we should have some workshops for the supervisors for mentorship, and I think we need to be trained, especially the younger ones. I mean, we are on our way out, but the ones who are coming in, I really feel they need, because that atmosphere of mentorship is not there in our training programs, I'm afraid.
Thank you very much, everybody, for a very fruitful session. I'm really thankful and obliged on the behalf of the Shaukat Khanum Hospital, Lahore, for all the participants who took their precious time to join us today. And I'm especially thankful to our seniors who had always been at the giving end to cascade what all they have learned in their life to their juniors. Thank you very much also.
Thank
Madam.
you.
Thank you.
Thank you.
Thank you. Thank you very much. Thanks a lot.
Thank you. Thank you.